not full screen. Okay. Good evening, everyone.
Good evening.
It's a great pleasure for me to invite all of you for our Plastiquest challenge session 6, online prelims in association with Apbc we are doing. So on behalf of team Plastiquest challenge, patron Dr. V. Bhattacharya sir and overseas faculty and Zoom platform sponsor Dr. B. Venkatratnam garu and our co-organizers Dr. Umar, Dr. Devi, Dr. Rohit and Usmania PG team and team APBC 25 for giving the opportunity. The chief patrons Dr. Matangi Ramakrishna Madam and Professor Dr. Rajiv Ahuja sir and Senior Advisory Council Dr. S.P. Bajaj, Dr. Arvind Vartak and Dr. Bilwani and Organizing Chairman Dr. Vinita Puri and Scientific and General Secretary Dr. Venkateshwaran and Treasurer Nilesh. I welcome all of you for this 6th session and judges of our Plastiquest challenge, Dr. Vijay Joseph sir and Dr. R.K. Srivastava sir and Dr. Sanjeev Gopal and Dr. Angeline Selvaraj madam. And today's session panelists, Dr. Pramod Kumar and Dr. Pallab Chatterjee sir and Dr. Harshvardhan. Moderators, Dr. Santakumar and Dr. Yogesh Bhatt and Dr. Manjula Bai. So today they are all senior professors and experienced academicians and 3 generations of the teachers are participating in this program. And for the first time, Dr. Pallab Chatterjee, Dr. Harshvardhan and Dr. Santakumar have joined for this session. So I would like to tell few rules and regulations of this Plastiquest challenge. It is a competitive as well as educative session. There will be 3 spotters and 2 teams are contesting for this. So one will be selected for the pre-finals. And there are 3 burn spotters. Each spotter will be discussed for 30 minutes. The initial discussion will be done by the panelist of the spotter for 10 minutes by asking questions. So the first question will be given to the team A. If they answer, they will get 2 marks. If they could not answer or partially answered, it will be passed on to the team B. And passed on question, if answered by the second team, they will get 1 mark. So the judges will be maintaining the scoreboard and the organizers will be stick to the time and they will be warning if time crosses. So we limit to the time to the spotter 30 minutes total discussion. After panelist, the moderator will ask questions for 5 minutes and followed by the judge of the spotter will give gist of the spotter and patrons and other faculty and PGs also will ask a few questions to the teams and this marks will be allotted. So finally, after discussing the 3 spotters like this, we will show the follow-up of the each spotter and later on feedback and the session continues. So now I request Rohit to take over and proceed the following session.
Thank you. Now I would like to request Dr. Devi Prasad Mahapatra sir to introduce the new panelists and the moderator to the audience.
Thank you very much, Dr. Rohit. Good afternoon, everyone. It is a pleasure to welcome Dr. Pallab Chatterjee to this session. Sir is completed MS surgery, DNB surgery, and DNB plastic surgery. Then he had his training in MAMC, Mamsi Hospital and Loknayak Hospital in New Delhi. Sir is an alumnus of Armed Force Medical College, Pune. And he was the ex-HOD of Department of Plastic Surgery at Division Command Hospital in Bangalore, and even ex-HOD of Army RR Hospital in Delhi camp. Sir is quite famous. He has been the winner of C.R. Sundarajan Gold Medal for standing first in the country in final exit exam in DNB Plastic Surgery. And he has been an examiner for Rajiv Gandhi University of Health Sciences, Bangalore. And sir has a lot of publications along with Dr. Ahuja and Dr. Handan's textbook of total burn care. I welcome you, Dr. Pallab Chatterjee, to this meeting. Plastiquest will be benefited by your presence, sir.
Thank you, sir.
It is my pleasure to welcome Dr. Shanta Kumar, who is currently the professor and head of the Department of Burns and Plastic Surgery at AIMS Mangalagiri. Dr. Shanta Kumar has done his MCH in plastic surgery from Ramachandra University in Chennai, and he has more than 17 years of consultant experience in plastic surgery and a lot of publication experience. And he has a lot of research projects with ICMR, BIRAC, and ISC Bangalore. And he has been a reviewer for Indian Journal of Plastic Surgery, for Journal of Advances in Medicine and Medical Sciences. Then he has a lot of interest in microvascular surgery and has experience in omental flaps, burn reconstruction, and as well as cosmetic surgery. I welcome Dr. Shanta Kumar to this session. We will be benefited by your discussions. Thank you very much.
Thank you, sir. Thank you, sir.
Then it is my pleasure to welcome Dr. Harsh Vardhan. Sir is working as an associate professor in plastic and reconstructive surgery department of KGMU, Lucknow, and he has done his DNB in plastic surgery with Dr. Harsh has keen interest in microsurgery and hand and as well as burn reconstruction also, and his interest is diabetic foot also. Welcome, Dr. Harsh Vardhan, to this session.
Thank you so much, sir. It's a privilege to be here, sir.
Okay, sir. Thank you so much.
Yes, sir.
One
Now I'd
more
like
thing, the Harshvardhan is son of Dr. A.K. Singh, sir.
Oh, doctor.
Very famous academician and experienced teacher. Welcome, Harsh.
Thank you so much, ma'am. Thank you.
ma'am, can I proceed to the roll calls,
Yeah,
ma'am?
yeah, please.
Before going to the program, I would like to take roll calls. It's like exactly 4 o'clock. Team 1, BJMC Pune. PGs from BJMC Pune, Team 1. Okay. Team 2, PGs from Sir Gangaram Hospital, Delhi. Are you there? Okay. Team 3, BMC Bangalore, PGs from BMC Bangalore.
We are here, sir.
Team 4, PGs from GS Medical College or KEM.
Yes, sir. We are here.
Team 5, Jipmar Pondicherry.
Present, sir.
Team 6, SMS Jaipur. PGs from SMS Jaipur. Team 7, PGs from AIMS Rishikesh. Team 8, PGs from AIMS Bhubaneswar.
Present, sir.
Okay. Team 9, PGs from Southeastern Railways, Kolkata.
Present, sir.
And Team 12, PGs from Mahatma Gandhi Medical College, Bhopal or Ganga Hospital, whoever is there. If you are late by 5 minutes or something, you just drop in the comment box so that I can add you for the question and answer session. Without much delay, madam, can I start with the spotter one?
Yeah, yeah.
Yes.
Teams,
We have two teams today. Team
BMC Bangalore
Yes, ma'am.
and KEM Mumbai. Welcome. So they will be contesting for this session. You would like to introduce yourselves quickly.
I'm Dr. Venugopal KJ, second year plastic surgery resident from Bangalore Medical College.
Yeah.
Dr. Narashri Iyer, second year plastic surgery resident from BMCRI.
Okay. KM students.
I'm Dr. Sohan, second year plastic surgery senior resident, KM Hospital. I'm Dr. Rishikesh, second year resident, KM.
Okay. All the best to both of you.
Thank you.
Thank you.
We'll start the first spotter now. So the spotter, the panelist for this spotter is Dr. Pramod Kumar, Professor of Plastic Surgery, PGI Chandigarh, and Dr. Santa Kumar, Professor and HOD, AIMS Mangalgiri is the moderator, and Dr. R.K. Srivastava sir will be the judge. So I welcome all three of you to start the session. Dr. Pramod Kumar sir. Dr. Pramod Kumar. Rohit, sir is there?
Ma'am, I have to check. I can't find, ma'am.
Probably he has not joined. So I think the
I'll call
moderator
him.
can start. Yeah.
Yes, sir. I invite Dr. Santa Kumar sir to finish your questions.
Madam,
I'll call meanwhile the Pramod Kumar.
actually, if something initially, hello, ma'am, I'm audible?
Yes, sir.
Yeah,
Yes.
yeah, sir.
Hello. The thing is, so to ask the question, I think initial discussion should be better, ma'am, because this is the new instrument.
Yeah, let them
no.
identify the team A,
No.
the equipment.
Let them identify and answer the question. We can
Hello?
explain later on.
Dr. Pramod Kumar from PGI Chandigarh. Please, already sessions. He's going to join. Meanwhile, the team A can identify the first spotter.
No, it looks like a dermatome, ma'am.
Any name?
Name of the dermatome.
Team B, can you? Team B,
Hydrodissector.
you don't know?
Hydrodissector.
No,
It
no,
is
no,
for
not
spotter
second
one.
spotter,
No,
first
no.
spotter. Name of the first spotter?
Ma'am, if you make the screen little bigger, it is better.
They
Yeah.
can zoom in and see, sir.
Yeah. Now it is better. Anybody can
Okay, team A.
just give the number.
Would you like to tell anything about that dermatome? It is dermatome.
Yes, ma'am.
But any name?
Would you like to name? They could not tell, but
No.
it is identified as a dermatome. They will get the marks. So you would like to tell anything details about it?
Ma'am, it's a power dermatome, ma'am.
Yes.
What kind of power dermatome? Any idea?
It's wired. It's a wired one.
Correct. The thing is, we are actually expecting whether it's a electrical, pneumatic, or something
Yes,
else.
electrical. It's an electrical one.
Okay. Can you tell where it is used? In specific?
Dr. Lakshmi, first we should give the marks for the first question. First question,
Sir, first question, 2 marks given. So team B, you can tell the use of this dermatome where in specific. Team B.
Ma'am, our face.
Pardon?
Okay, the question should pass to team A. Okay.
Yes, like in a smaller surface area when you are taking the graph from a small surface area.
Like any particular areas preferred?
Uh,
On the face and on the neck areas.
Okay.
There are various dermatomes. What is the difference between that and this? Hello?
yeah, this is like in a circular fashion. It will take.
Yes.
Okay.
I don't know that you have joined. Okay, please. Yeah, please. You have to ask. Sir already there in group. He will ask the questions.
Hello.
Yeah. Please continue.
Now, which team is there on the
Now,
answer?
team A.
Yeah, team A. So, what is the special thing about the use of this type of dermatome?
The graft can be harvested in a like in a
Like
circle. Like,
all the
Sir, your
so there's a
voice
disturbance
is
in the audio,
breaking.
sir.
Audio is not good, sir.
Hello, am I audible now?
Yeah.
Stop the video. Hello, is it audible?
Yes, sir.
Yes, sir.
Yeah.
Yes, sir.
I was asking what is the special advantage of using this type of dermatome?
We can harvest the graft from a smaller donor area, sir. In children,
Okay.
can be used in children.
You know what type of blade is used for this type of dermatome?
No, sir.
Okay, fine. And ma'am, can we go to the next second spotter with the same team, or we have to change some sequence?
No. Next question will be asked to the team B.
Team B, okay.
So
okay.
what marks you
So
are
what
going to
marks?
give to the team A? Team
Hello?
B, would you like to anything contribute for the answer?
No.
No. Okay. So team A will get only 1 mark.
Okay. So now the second question to team B.
Team
Because
B,
first
second
question
spotter,
they didn't
second spotter, they have to identify.
This is the Versajet hydro dissector.
Dr. Pramod Kumar, you can ask.
What part of it is? You have to be very specific. Versajet is a big system, no? What is this?
Needle which we inject. It is the tip of the. It is a dissector tip. This is a dissector tip, sir.
It's a hand. Okay. I
Team
cannot
A,
tell.
Team A, can you answer in specific? Can you?
No.
No. Okay. Pramod sir, you please give the marks and continue.
Okay.
And you
Sir,
can
can
tell
we
the
give
answer
them the
also.
full marks or half?
It has to be half marks because they have not been very specific, because Versajet hydrodissection system is a big system. This is a part of it, and then they have to be specific for that. I would offer half the marks. And
Okay,
next is team A or B? Team A.
Team A.
Team A.
Yeah. What is the special advantage of using this type of instrument for debridement?
So yeah, simultaneously it will debride and irrigate. Irrigation also will be there, and more like it will be more.
Is it a irrigation system that is being used for debridement?
Yes.
What
At
is
the
the
source,
advantage? What is the
with
advantage?
What is the advantage?
It's more precise.
Precise in what?
You want to convey what with respect to precision?
Yes, sir. The depth.
Actually, we cannot answer in words. We have to
Okay.
answer in sentences.
The precision of the
Yeah, okay, go
Yes.
ahead.
Yes,
precision of the
tell
depth.
Venu.
Depth. Precision of the depth, ma'am.
Depth
And
means what?
also,
What it does?
like
What
until
it
the
does?
like the
Only the slough part of the wound will
Yeah.
be debrided, so that till the healthy part of the wound, like we can debride only the slough.
Yes.
Okay.
It's not
That's
the
better.
slough. In specific, you should tell non-viable tissue.
Yes.
Yeah. Okay.
Okay.
Now,
They have the concept, so we can give the marks.
marks, yes.
Full
Yeah,
marks, madam.
2 marks. 2 marks.
Okay,
Yeah.
okay.
Next question will be to team B.
To team B.
Yeah. Yeah, team B, the question for the hydrosurgery system is that what is the principle used in this type of dissection system?
The injected to
Hello?
the
Hello?
hello. The injected tumescent fluid created a dissecting plane in between the non-viable and viable tissue, so that the dissection of the slough will be easier and precise.
I'm not very. Can you repeat your answer, please?
The injection of the tumescent in between the
You are not getting the point. I'm asking what is the principle of functioning of this handpiece? This is a Versajet handpiece. What is the principle of its functioning? How does it? What is the principle on which it works for the debridement?
Venturi principle.
Yeah, that's better answer. Okay, fine. It is the Venturi effect where it works. Fine.
middle
Yeah,
pulls
this is a
Full marks, sir.
yeah full mark, ma'am.
Okay.
They have answered.
Next question to team A.
Team A.
It is only one part of the answer, actually, Venturi effect.
Then team A can supplement. Can
the
team A supplement?
jet of water, jet of fluid is irrigated under controlled pressure. That is the principle is used.
Nini, the principal part has been said. You have to tell what is the additional advantage.
Vacuum is also used. Yes.
Nini, that is fine. That is the purpose of Venturi effect. What is the additional advantage as sir has pointed now?
Yes, sir.
What is happening there? Once you debride, what is simultaneously happening?
Like it's sucking of the slough is also done. Irrigation and aspiration is also being done.
Yeah, that is happening there because it is debriding, specifically debriding the dead tissue, and simultaneously it is irrigated from the area.
So one
So-
mark each?
Yes, yeah, ma'am.
Yes. Ma'am, not 2 for
Okay.
team B. It is 1-1. Okay.
Okay. So now question to team A.
Question to team A.
Any other panelist who wants to ask question? Because
If your time also over. Now Dr. Santakumar, please
Yes, ma'am.
continue the questions.
Okay, this is regarding the dermatome, amalgamate dermatome. This is question to team A, ma'am.
Yes.
Okay,
Team
okay,
A.
okay. Just one question. Maybe I think with logic people can answer. Can it be used in all the parts of the body, or any specific area we should use, or Any contraindication to the particular areas? Team A.
Near the creases is contraindication near the
Which creases? No, like why?
near the groin or the
groin, and most important is especially uneven surface like eyes and ear.
Yes.
Yeah, those are the that's what. Why it cannot be used there?
Since it's a circle, it takes the graft in a circular fashion. The chances of inadvertent injury to the
surrounding
uneven
tissues.
surface. Yes.
That's what. That's what. Okay. And actually, this is a pneumatic dermatome. Ma'am, next question to be asked, or is it?
B, team B, sir.
So we'll give the full marks to them, sir.
Are you happy with his answers?
Yeah. That is the what we wanted actually.
Okay,
Yeah.
two marks will be given.
2 marks to team A.
Team A. Team B is next question.
Actually, not because since it is not used in India, not many people doesn't know about this. No? I don't know. Very limited questions to ask in this.
Sir,
Okay.
if I
Yes.
may, I would like to add that are we finished with the session, or we still have to ask more questions?
Maybe
You
other
can
people
ask.
may-
You can ask to team B.
Okay. What
Yeah.
for spotter 1? What is the
Yeah.
largest size of the graft that can be harvested with spotter 1?
Team B. Team A.
No specific answer.
Can guess. No negative marking.
Maximum up to 10 centimeter.
No, it's the wrong answer. Ma'am, can I tell the name of this instrument to the?
Yes, sir. Now
it is.
I think Judge Dr. R.K. Srivastava sir can do
Fine.
or
Definitely.
will finish the questions of the patron and other faculty because they also carry some marks. So
Definitely.
we'll finish.
Okay, ma'am.
Sir.
So should I?
Sir,
The
before
first
giving the
spotter.
details, you can ask questions, sir. Don't tell the details totally.
I don't think they will be able to answer the questions related to this.
Yeah.
Only about this hydrosurgical instrument, they can answer few things, but
Yes, sir.
till now
That
they have
will
not
score the
given that.
marks.
Yeah.
They can score
It
the
acts
marks.
centrifugally or centripetally?
Team A.
Team
A, sir. A. No.
Team A.
Versajet, no, sir?
Yeah. The hydrosurgical instrument, I am not taking the name. Otherwise, it comes only by this name.
Yeah. Team A,
Sir, can you repeat the question, sir?
centrifugally or
Okay.
centripetally?
Does it act centrifugally or centripetally?
Centrifugal, sir.
Centrifugal means from where will you start?
From the outer part to inner part.
That will be centrifugal. So B, what is centrifugal?
Into
inside.
into
Huh?
from out to inward, sir.
Okay, now I should give the gist because they will not be able to answer.
Yeah.
First, the dermatome. This is called amalgatome. This instrument is in two forms, SD form and MD form. Basically, the instrument shown here is MD form, and that is used for cadaveric harvesting, skin harvesting. You can go to uneven surfaces and it is very easy to operate. It is pneumatic instruments. That's why this has been developed. The circular disc is there and blade is a disc type, circular. So you can work 180 degree. You can maneuver it 180 degree. Okay.
Yes.
So, and this form is the MD form, as I said, and the second is SD form. That is used for wound debridement and skin harvesting on the living people also. This MD form is only for cadaveric purpose. Okay. The second thing is there are much more details you can go through the net. I am not going into that. The gist is that. And the hydrosurgical instrument uses high pressure coherent beam of this water. It utilizes 15,000 pounds per square inch of pressure. And with that, the handpiece water jet comes out from the jet. And because of Venturi effect, the debris which comes out because of that pressure, it works horizontally over the surface. And it is taken up by the suction. This acts centrifugally. That means you start from the center and go to the periphery. In that way, you do not damage the nearby areas, the normal area. Whereas your mechanical, it is form of mechanical debridement instrument. In other mechanical debridement methods, you go centripetally from out to inward. Okay. So these are the differences. Now, Pramod, you can ask the question. Dr. Pramod?
Yeah, yes, sir. I think you have added a lot of details to it. The major part is that the one thing that they were not able to answer is that the largest size of the graft that can be harvested with this amalgam.
Yes.
If you are working on a cadaver, you can go from ankle and you can go up to the nape of the neck on the back.
Yes.
It is this much
Actually,
big graft
length
that
is not a problem. The width.
Width.
Yeah.
Yeah,
Width,
width is
anything.
actually the size of the disc that it determines. Most of the time,
Yeah.
it is 8 to 10 centimeter disc that is available, and it is not used
Usually
on
it is
small.
8 to 10 centimeter one.
Yeah, it is not used for debridement of small.
That SD form I am telling, this is not used for that.
Yeah,
because there
not
is
used
a
for
thickness
small,
difference. This MD
Definitely.
form has the thickness of 0.001 to 0.040, and that is having the SD form is having the thickness varies from 0.005 to 0.045.
Yeah, sir.
So
And the
these
main
are the
disadvantage,
differences, very minor difference.
yes, sir. Main disadvantage is with Versajet is that because it produces lot of fumes and aerosols. So we
Aerosols
have
it
to be,
produces.
yeah, so we have to be very cautious that we have to
Yes.
use it very precisely. If it is
Basically, its
wrongly
purpose is
used, then it
wound
produces lot
debridement.
of
Versajet
aerosols.
is not effective in
Yeah.
other things. As
Yes,
they say,
definitely.
you can use it for partial thickness burns even immediately after the burns while debriding for this tangential excision. That is not correct. I think it is sufficient. Next pattern should
Thank you.
ask question. These are costly instruments. That's why they might not have been used at our places. Even I could not get the price of this amalgam.
No, sir. Actually,
This is specifically made by ExcoSurge, and I don't know what is the price.
Yeah,
I think it is on demand.
We try to get it, but the thing is that the company people who are making it, they do not want to sell it in India. I don't know what is the.
They are mostly selling it in USA, and price is on demand. So in India, they don't want.
Yeah, definitely.
Yeah, but it is definitely effective for cadaveric harvest.
Yeah, sir, quite effective.
Yeah. It might
it
come to
a-
India after some time. Sir,
Is it F-35?
yes, sir. It's very useful and being used in USA for
Yes,
even
FDA certified.
at SD form for even graft taking and wound debridement.
Any PG teams or faculty would like to ask any questions? Bhattacharya sir?
Yeah, I'd like to ask that regarding the hydro dissector,
Sir.
what type of scar you deal with? What is the indication? Type of scar, type of stuff, type of scar, where it is indicated. Any idea?
Team A?
Precise indication in respect to type of scar and the zone.
So it's mainly a zone of coagulation where the dead tissue is there. Non-viable tissue is there. That's the zone we need to use.
Non-viable tissue is okay. Slough is also non-viable. Other
Yes.
deep scars,
Yes.
devitalized scar are also non-viable.
Yes.
So in every case, will you use it? That is number one. Number two, where it is more useful, in which areas? The other team?
Team B?
Team B.
The trunk or extremity.
I mean, which area it is more useful, more precise?
Over the trunk or extremity. Over
I'm asking about the hydro dissector.
uneven surfaces where a tangential fixation cannot be.
No, the answer is the critical areas where you have finer folds like periorbital area, perinasal area, angle of mouth. These are some of the areas where you have to be very protective. Near the ear, again, on the ear, suppose there is a slough, the helical ring. So you have to be very precise. This gives a precise excision, precise debridement of the wound. Therefore, critical areas are these. And the type of scar is where it is more adhered, so that your hydro dissection demarcates between the viable and non-viable in that particular plane, so that you don't unnecessarily excise also. Otherwise, you can use a dermabrader and somebody sprinkles water on it. It is not same. Okay, so there is a difference between debridement. So these are very precise zone and precise depth.
Sir, can I add one thing more?
Please.
It is useful for uneven surface like
Yes.
deep, if the wound is deep.
Yes.
I'm not talking of burn wound.
Yes.
The other type of wound like
Other type of wound.
foot and the wounds with slough. So
Yes.
your reach is better and the slough can
Yeah.
come out from that.
For example, on
because
the
you
chest.
cannot take it out from blood.
Yeah,
Yeah,
on the
chest.
chest when
and
there are
foot.
ribs and there is a
Yeah,
waving.
dorsum of foot or sole or
Yes.
where the bone is involved and there is slough. So
Yes.
there also it has quite
Where
good use.
where you expect there are underlying viable vital structures which you can
Yes.
protect and prevent
Yes,
from
sir.
unnecessary debridement.
Yes.
Thank you.
Thank you, sir. Rohit,
Yes, ma'am.
any PGs would like to ask anything, or we'll proceed to the second spotter?
Team 4, PGs from KEM Mumbai. You have any questions to Team 1? Team 4?
Sir, I would like to know whether is there any contraindication that they can quote for Vasajit or hydrodissection?
Team A. Team E?
No.
You don't know the answer? Then Team B?
No, sir.
Okay, you just answer the question.
So is there any active infection? It's better to be not to use this thing. And the other thing is if the patient has any active bleeding issues like antiplatelet drugs.
Okay. Now,
Is
team,
the absolute contraindication? Is that an absolute contraindication?
Dr. Girija?
No, sir. I was just asking for the where it needs to be relatively contraindicated. When they should be cautious of using the hydrodissection.
And active infection is also a contraindication. Huh? It is can be used, no?
There's some this thing written that if there's high chance of spreading the infection to the normal things also because of the pressure.
Okay.
If there's active flux.
Okay.
Yes.
Thanks. Okay. Thanks.
Thank you, sir.
Yeah. Rohit, proceed.
Okay, sir. Thank you. Now, I'd like to request any question from Team 3 to Team B.
No question, sir.
Yes. You don't have any question?
No, sir.
Team 5, Jipper Pondicherry, you have any questions to Team B?
No, sir. No question, sir.
Okay, fine. Ames Bhuneshwar?
No question, sir.
No.
Think we'll
Kolkata?
move to the second spotter, Rohit.
Madam, actually, we have to ask one question to Team B, madam, to
Okay.
police.
Oh.
So asking other teams who can contribute at least. Southeastern Railway, you have any questions? PGs from Southeastern Railway. Okay, fine. Sir Bhattacharya, sir, you can just, if possible, you can ask one question to Team B, sir, so that it equalizes the scoring system. Bhattacharya, sir?
Yeah.
Sir.
After debridement, how soon you can resurface the wound? If you use the hydrodissector, is there any specific advantage of using hydrodissector and resurfacing of the wound? How soon you can do it? In other words, how can you be? Are you be so sure that hydrodissectors one sitting will be enough to reach the viable tissue and all the things are debrided?
Yes, sir. We can resurface it immediately.
Can be immediate?
Yes, sir.
How do you decide that? That yes, the wound is ready for resurfacing.
From pinpoint bleeding, and with the visible viable tissues underneath.
Right. Is there any role of going little deeper with the hydrodissector because more precise, or whenever you reach the plane where there are punctuated hemorrhages, you stop there?
We go a little deeper than punctate point bleeds.
How do you decide on the table? Very practical question. That your debridement is complete. Suppose you have debrided, okay? Then immediately somebody takes a graft or you take a graft and put it there on the table. What do you do? And that is true for all debridement. Suppose you complete debridement, then after that, do you wait?
We will, sir. There will be punctate bleeding, and we will try to control the bleed with with adrenaline soaked mop and. And in this case of hydrodissection, that fluid
Yes,
puts to the
you can do adrenaline or even normal saline. You should put a soaked gauze piece to the next team or to the B team only. Yes.
Next
So
team.
you need to wait.
till the play stops, sir.
Yes, because it doesn't happen immediately. No, this is true for all debridement.
Yes, sir.
Yeah. So you get 1 mark.
Okay, sir. Thank you so much, sir. Madam, if you allow, I can move to the second spotter.
Yeah.
I would like to request Pallab Chatterjee, sir, to start questioning.
And I have one question, ma'am, at the last.
Yes, sir. Yes, sir. Madam, I think Arun Kumar Chaudhary, sir, is trying to ask some questions. Should we wait, or I think he's having some network issues also.
Sir, we'll go ahead. It's already 8 minutes crossed.
Yes, ma'am. Yes. I would like to request Pallab Chatterjee, sir, to start questioning.
Yes.
Thank you, sir. Thank you.
So, just to give both the teams a little bit of background, this is a 3.5-year-old child who fell into a bucket of hot boiling water. Very unfortunate, very painful. And after that, he sustained the kind of injury that you can see. So my first question will be, how do you assess the depth of the burn when the patient comes to you?
Team A.
The depth assessment is primarily done clinically. If the wound is looking pink, then it's like with blisters. Then the second degree. In this picture, it looks more of a second degree superficial burns and the patches of deep second degree burns. Most of it are superficial second degree burns. The wound looks pink, and on clinical examination, capillary refilling time also we need to check. If there's a brisk capillary refilling, that confirms that it is a superficial second degree burns, and it's also by history it's painful.
Okay, so but how do you distinguish between the intermediate burns and the deep burns? So erythema, we all know, is first degree.
Yes.
We're not even talking.
Yes.
Superficial second degree, there will be blistering. The whole game and the discussion is clinically, of course. We all can be wrong. That's a different thing. But clinically, how do you distinguish between intermediate depth second degree and deep dermal burns?
Yeah, in the intermediate, still the pain sensation will be still present, whereas in the deep, only on the pinprick they'll have the pain sensation, whereas they'll not have the sensation when we touch it.
Okay.
And on capillary it looks more paler when compared to intermediate depth, it's more like a pale tissue when compared to a pink tissue which is there in the intermediate depth.
Also, the presence of thrombosed vessels underneath the tissue can be seen.
That will be full thickness. We are not talking of full thickness burns. Please understand, we are talking of intermediate and deep dermal. Okay, so.
And capillary refilling also will be will be brisk in the intermediate, whereas will not get a capillary refilling.
It will not be brisk in intermediate. There will be,
yes,
there will be slow capillary refilling if at all present.
And fixed capillary staining will be there in some places in deep.
The deep dermal burns usually appear what is known as waxy eschar.
You can ask the second team to contribute, sir, if you feel it is not complete.
Okay, then it will go on to second team. So second team.
No, sir. In the same question.
In the same question.
Complete answer.
Okay.
You think A hasn't answered completely.
Yes.
So you can ask team B to answer.
I think they have answered the question completely. So now I can go on to the next question, which can go to team B.
So team A gets 2 marks.
Team A will get 2 marks. That's right. So now the question to team B is, how do you estimate the surface area of the burns in children?
In children, we use a London Browder chart for assessment of the burns.
So immediate question is that how is London Browder chart different from Wallace rule of 9?
Wallace rule of 9 uses main anatomical region as 9% and main anatomical areas as 9% and calculate it to total 100%. But in London Browder, it gives weightage to the head of the child and trunk.
How much is the percentage of the head and neck in London Browder chart, and how much is there in the Wallace rule of 9?
So in first year of life, it will be 13%, and it 1% decreases with increase of age till till young adult, sorry.
Did you say 13 or you want to revise that?
18, sir. Sorry, my mistake.
18. Okay, good.
Then-
So where do the percentage decrease?
Sir,
Hold on. If you have 18% for head and neck in London Browder chart, which is 9% in adults, so where is this 9%, extra 9% coming from? Or where is it getting reduced, in other words?
Extra 9% get adds to the limb, sir. Mostly low.
Good. So team B also gets, ma'am, the correct answer.
Yes, sir. Next, you can go ahead to team A.
Yeah.
Next question.
Yeah. Next question to team A is, suppose it was superficial burns, second-degree burns, and the patient, forget about this patient. Suppose the patient has come with blisters. What will your management for blisters will be?
In general, like if there are two schools of thoughts, like one school of thought says that don't rupture the blister, it acts as a mechanical barrier for the wound. But the other school of thought says that if the fluid which is there in the blister is a proteinaceous fluid, which is an exudate, which acts as a nidus for infection. So it's better to rupture the bleb and then do a closed dressing.
What will you do? What is your school
I
of
will
thought?
go with a rupture the bleb and do a closed dressings.
Rupture of the bleb. So the answer is by and large right. I will, ma'am, grant the marks to them. The importance of deroofing the blisters is sometimes in these cases, not the theoretical question. We have to assess the involvement of the burn. So it is very important to deroof the blisters in order to see the area of involvement, which may sometimes not be possible with the intact blister skin. The question goes to team B now. So what will be this patient? This patient incurred this injury around 100 kilometers from our hospital, and then the patient had to be transferred to us. What are the considerations of transferring a burnt child or a burns patient to a burn center?
As a primary on-site treatment, immediately after the burns, we will give.
No, team B, you are not understanding. What are the considerations for transferring a burns patient to a specialized burn center? Why can't this patient be managed in a primary health center? Yeah, nowadays you get everything. All the primary health centers are also equipped with sulfadizine and dressings and every other thing. Many of them might even have Acticoat in better staffed and better equipped PHCs. Is the patient supposed to be treated there, or the patient should come to a accredited burn center?
This will require a specialized burn care unit for treatment, sir, because it's a 3.5-year-old child with superficial partial thickness burns involving more than 15% total body surface.
More than
10% body surface area.
More than 10, that is good.
Body surface area with involvement of genitalia.
Yes. So extensive burns, then involvement of genitalia, burns more than 10%, burns that require IV fluid resuscitation, and of course, lack of expertise in the primary health centers.
You can ask the if they didn't answer fully, you can give
No,
opportunity.
they answered. I don't have to get the answer out, but they have answered, ma'am. So the marks can be given to them. So now the question comes to team A. What kind of fluid resuscitation will you do in this patient?
The fluid restriction, we need to concentrate mainly on two things. Since it's a child, the glycogen reserve, reserve is also less. We have to give resuscitation replacement fluid, also the maintenance fluid in the form of sugar containing fluid, the dextrose containing solution. So I'll go with ringer lactate as a for the replacement fluid and half DNS for the maintenance fluid, sir.
No, ringer lactase as the replacement fluid, that is not the complete answer. Please give the complete answer. What is the formula or what is the calculation? Suppose I were to
Sir,
tell you.
Yes, sir.
I'll
go.
Hold
Yes,
on. Suppose I were to tell you that this patient weighs 15 kgs and has
Yes,
got 45% burns.
Yes, sir. My calculation will be 3 ml into the total body surface area burnt into the weight, that is 15 kg. I'll calculate from the time of burns. I'll divide it into 2 halves. The first half will be given in the first 8 hours and the next half will be given in the next 16 hours. Along with that, I'll calculate as per already cigar formula, I'll calculate the maintenance fluid also, which will I'll give the dextrose containing
What is
fluids.
the formula for calculating dextrose containing dextrose maintenance fluid?
So for the first 10 kgs, it's 4 ml per kg per hour. For the next 10 kgs, it will be 2 ml per kg per hour. And the further after 20, further like it will be for each kg, it is 1 ml per kg per hour.
Very good. So full marks to team A. Team B, in the replacement fluid that team A just alluded to, replacement fluid, ringer lactate, what is the role of giving any colloid containing replacement fluid or resuscitation fluid?
Sir, in the first 24 hours, I would abstain from giving any colloids, and on the next day, I will start giving the colloids.
What is the scientific logic behind it?
Because during the immediate burn period, the capillary there will be a capillary leak leading to the loss of the colloids also into the soft tissue, which aggravates on to the burn edema and shock, sir.
Okay, and what is the time duration when the capillary integrity is restored?
In a normal tissue, it will restore in 8 hours, and in burn tissue, it takes around 12 to 36 hours.
No, not exactly 36 hours. It starts getting back after 12 hours. And by 24 hours, usually the capillary integrity is back. Ma'am, I can give half mark to this. Otherwise, the answer has been correctly stated. So team A, now the question comes, what kind of dressings would you like to do for this patient? You are going to, of course, do some dressings for this patient? Or are you going to do exposure method?
No, I'll go with closed dressing, sir.
Closed dressing. So what kind of dressing would you prefer and why?
Sir, I'll since it's extensive burns, like depending on the water and availability also, like and the patient affordability also we need to think. I'll go with silver.
The patient has come to BMC. BMC has got everything.
Yes, sir. I'll go with silver coated foam dressings, Mepilex dressing for this patient, sir. Since it's a kid, I don't want to give repeated dressing, so I will avoid topical antibiotic ointments. I'll avoid, sir. I'll go with the foam dressing since it's a kid, and I can cover most of the areas. And like I don't want to do repeated dressings, so I'll go with the silver coated foam dressing, or either Mepilex or any silver coated foam dressings.
Okay, question to team B. Team A just said Mepilex. There is another dressing called Acticoat. What is the difference between the two?
Team B.
How is Acticoat different from Mepilex? Ma'am, team A has answered the question correctly. I agree with them. We will not do dressings very frequently. We would like to give dressings that stay on for some time so that the dressing changes, the painful dressing changes are minimized.
Yes, sir.
Now, team B, I'm asking you that what about the difference? Have you heard of Acticoat?
Yes, sir.
Okay, so what is the difference between Acticoat and Mepilex? Team A?
Sir, Acticoat is a silver nanocrystal based dressing and which doesn't have that foam, absorbent foam, sir. It has to be covered with some this one, sir. Like it
No,
has
no.
to be wet.
How
It has,
does nanocrystalline silver differ from the silver in any other dressings, or even for that matter, AgNO3?
sir,
What
like
do you mean by
the amount of
nanocrystalline silver? Let's come to this.
How
What do you
will
mean by nanocrystalline silver?
the amount of silver, the particle of the silver and the
No, not that. Team B, what is the charge, ionic charge on the silver?
Positive, sir. Positive.
What positive?
1 positive.
+1, +2. What is the implication of this positivity? And now do you get the hint? What do you mean by nanocrystalline silver?
It gets integrated into the bacteria and keratinocytes, which inhibits
No,
any.
no. I think we'll leave it at that. You will have to understand about my nanocrystalline silver. So we will leave it at that about the dressing part. So now back to team A. The question is, how will you manage this patient? Will you manage the patient with only dressings, or will you manage the patient with surgery? First, answer this question.
Yes, so first I'll go. First is the first aid. First is assessment of the burns, and then the primary resuscitation in the form of fluids. When come to and analgesics, and when come to dressings, most of the areas are superficial second degree
Team
burns.
A, you have not understood.
Yes,
I'm asking you whether you will take this patient for surgery, you will do any surgery, or you will just decide that we will do conservative management.
No, sir. Like in this picture, the first picture I can make out.
I can tell you that there are certain areas that are red. It's a
Yes, sir.
mixed kind of pattern when the patient has fallen down. So there are
Yes.
certain areas like over the knees, over the buttocks,
Yes, sir.
chest, over the
Sir,
chest. Actually, on the first photograph, you can see that over the
Yes,
chest
sir.
is deep waxy scar. Now, the patient has got. I'm telling you, the patient has got deep dermal burns. Now, tell me,
Yes.
what will be your management? Whether it will be.
Sir, yes, sir. I will in the first picture, by what we see is over the thigh and the knee region of the both sides. There's some deep burns. I'll go ahead with early tangential excision and under anesthesia for this part. And the other part, I'll go with the dressings, the conservative management. And I'll immediately in the same sitting, I can do, since the donor area is also less, I can go ahead with allograft also. Or immediately after that, and later on when the wound bed is ready, I can go.
We'll come to that later. Team B, what do you mean by tangential excision?
In a tangential excision, we slice the
slice.
Using a grafting blade, we excise the layer of tissue, layer of the non-vital tissues, layer by layer, till a punctate bleed will come, sir. So that means viable till we reach the viable tissues.
Okay, so this procedure, when you carry out layer by layer excision of non-viable skin or the dermis till you reach the viable dermis, so this procedure actually causes a lot of bleeding. What are the strategies to reduce blood loss, Team A?
Sir, one thing is we need to, if the periphery is, for in this case, we can use tourniquet, sir. Tourniquet is one of the thing, and the thing is, like, if you do early tangential excision, the blood loss will be less, the thromboxane levels will be more, so that the blood loss will be less. If you take it delayed, then the bleeding might be more, so that is one more thing. And immediately after the, if you consider the bleeding is more, you can immediately after tangential excision, you can just do the dressings, and you can take the patient again for grafting on a later date after 24 to 48 hours to prevent the bleeding, sir.
Okay, so Team A, correct answer, ma'am.
Team B. Sir, I would like to know whether you accepted the previous Team B active coat this thing, or do we?
No, I did not. I did not, ma'am. Team B was not able to tell
the
about
answer. Okay, so no marks for them. So
No
for
marks.
this, you accept Team A's answer fully, sir?
Yes, Team A's answer.
We can ask of other modalities. He told only the tourniquet. So
Yes.
what else can be used to reduce the bleeding while tangential excision?
Yes.
Yes. Like we only I'll only tell the other methods also. Like we
Yes.
told tourniquet, and
Yes.
like if the bleeding is more, like we can use like
You
immediately
don't
dressing.
estimate the bleeding is more or less. What you will do to
Yes.
prevent the bleeding?
Infiltration, tumescent infiltration. We can
Yes.
give epinephrine
And
in
what
the
else?
infiltration.
What else?
Yes. Then like if it's like we can.
Topical anticoagulants can be used like fibrin.
Yes. What else? Before shifting the case into theater also you have... Yes.
Undergoing transfusion and maintaining the nutrition of the patient, and vitamin K supplementation can also reduce blood loss during surgery.
Venu is telling something else.
Like we can use the fibrin gel also, like topically, and
okay.
And blood
Maximum you
transfusion
have
also
answered.
we can, if the hemoglobin is less also, we can consider blood transfusion also.
That is a different thing. That is not
That
the
is not
strategy
the
to
thing.
reduce. That is not the
Prevention.
strategy
So
to reduce.
tranexamic acid injections
Yes,
and infusion also you can put during the procedure. Okay.
Yes.
So maximum you answered. So 2 marks.
Okay, madam.
So back to team B. Now the question is, you have excised the wound, something which team has said, but now the question formally comes to you. You have excised the wound, there is a raw area now, and you have gone to the level of viable dermis with punctate bleeding. Now, what are your options of coverage?
We can use his own his own auto grafting of his STSG. Then allograft can be used. Then we can use SL or dermal matrix resell technique.
Resell. Okay.
Staying of
Okay. Can you tell something more about resell, since you mentioned resell?
Sorry, it's a type where his own autogenous graft is sliced into pieces and sprayed over the larger area.
Over the larger area. Okay. Ma'am, the answer is right.
Yes.
2 full marks.
2
Okay,
marks.
madam.
Yes. Now, suppose we have, let us say,
Sir, only one question more. Time is up. So,
okay, one question, ma'am. So, okay. So once the surgery has been done and you have put, say, allograft on this. Now, when will you change the dressing?
team A.
Team A.
Team A.
Like I'll
change the dressing.
like after 4th or 5th post-op day, sir.
Why? And the reason why? Why not 2nd day? Because we are very concerned about infection, aren't we?
Yes.
Why not 7th day? Sometimes, I mean, if we have done the procedure in the sterility, in the sterile conditions of the OT, then why should we even fear? So
we need to know the whether the allograft is this uptake of allograft or
allograft uptake will always be there. A burns patient is immunocompromised.
Immunocompromised.
That is the logic of take of the allograft uptake will always be there. So don't worry about that. When do you want to inspect the wound? Because inspecting a wound in this patient is a huge task. You cannot just do it by the bedside. It may be difficult. You may have to take the patient to the OT under sedation to do this. You don't want the skin graft or the allograft, precious allograft to move, to shear. When is the date? Which day will you do it?
The 5th post-op day.
Reason?
There's one decorated.
Sir, ma'am?
No,
Reason
sorry.
Okay, so then last question to team B. What are the stages of skin graft take? And what is the time duration of skin graft take?
Sir, do we give full marks to him, the team A?
Yes, ma'am. He has answered, though he was not able to answer. Ma'am, we'll give him half marks because he was not able to explain the reason.
Reason, okay.
Yeah, let us see if team B is able to tell us about the process of skin graft uptake and the timelines.
Team B.
Sir, first of 48 hours, it takes its vascularity by inhibition, and next 2 to 5 days, it take nutrition by inosculation and then neovascularization thereafter, sir.
Thereafter. So, what do you mean by inosculation?
Inosculation is when the blood vessel from the derma from the bed touches the blood vessels that are exposed to the graft from the graft side. So,
okay, your terminology is exposed and all that terminology is not correct, but materially what you're saying is right. So, when does the revascularization occur? On which day?
After 1 week, sir, 7 days, 5 to 7 days.
No. I think you said it earlier. The correct thing, 2 to 5 days. It is from the 5th day.
Yes, sir.
Skin graft gets revascularized. You had said this earlier. I wanted to hear it in clear fashion from you. And
sorry, I thought revascularization you were asking. That's why.
Yes, revascularization I'm asking. The blood flow starts from the 5th day onwards. Okay. Then the maturation of the skin graft takes place. Ma'am, we will give now you team A, you get the answer. The reason why 5th day is so-called the default setting for inspecting the take of the skin graft. Ma'am, team B, we will give full marks because he was able to tell about 48 hours, 2 to 5 days and 5 days onwards. Thank you, ma'am.
How much, sir?
2 out of 2 for team B.
How much, sir?
Full marks, ma'am.
How much, sir? 2 marks for
2
team
marks,
B.
full
Okay.
out, full marks.
Okay, sir. Okay.
I'm finished, ma'am.
Madam, now I'd like to request Yogesh Bhatt, sir, our moderator.
Yeah, the first question, I mean, team A is, sir has asked you, when will you, transfer the patient to a higher center? So what will, if you are a casualty officer in the casualty, which are the few criteria you will assess the patient, burns patient of this, 45% of burns when you treat the patient, see the patient first time? How will you assess the patient?
Resuscitation in the first thing is like if the patient has immediately come, then we need to cool the burn wound. For that, we need to do hydrotherapy in running water with a room temperature. That's the first thing I'll do, and simultaneously I'll assess an IV line and start a resuscitation fluid as per the Parkland formula. In the same time, I'll look for any like in this patient, since the head is not there, there's no facial injuries or anything, so there's no inhalation injury. But I'll give 100% oxygen to the patient, and after I'll start the resuscitation fluid, and then after that, after I'll go with the analgesic to the patient, and then I'll do the dressings and catheterize the patient for the monitoring of the urine output, and also there's a genitalia burns also, and I'll this will be my initial initial thing which I'll do in this patient, sir, and the positioning of the patient, since the joints are also involved, like I'll give the comfortable position for the patients.
That's good. I think the answer is good. Perfect. Team B. See, we have discussed about the fluid replacement therapy. We have assessed the patient. And now after starting the fluid, how will you monitor the patient, like whether the treatment is going perfectly all right or not?
We will assess the urine output hourly after the giving the fluid, and the urine output will be maintained from 0.5 to 1 ml per kg per hour urine output.
Okay.
And we will assess his vitals also, pulse rate, blood pressure, and his respiratory status and also. And we will assess his arterial blood gas to assess the lactate levels and any metabolic derangements for this patient.
Okay. So what is the requirement of a metabolism? I mean, the nutritional in case of burns,
Sir, is it for
So,
team A or B?
Yeah, now the
Because
team B has given full answer.
what
Perfect.
about team
Yeah,
B? How many marks, sir?
full mark.
Full
Okay,
marks.
sir.
So now the
Okay.
question is to team A.
Team A, yeah. Tell us about something about the nutrition of the burns patient, especially in children.
Nutrition is like here in this, we need patient requires the calories and also the protein, sir. We need to calculate the calorie requirement as per the Curie or Sutherland formula and the protein requirement as per the Davis formula, sir. In the children, it's like 3 grams per kg plus the 1 gram per each body surface area burnt. We need to calculate the protein requirement and the calorie requirement as per the Sutherland formula. We need to calculate, sir. 65 kilocalories per kg plus 40 for the plus 40 kilocalories per the total body surface area burns.
Okay. Team B, tell us something about now. Suppose the initial wound is no infection, but how will you monitor the infection? What is SRS, systematic inflammatory reaction syndrome? Which are the criteria we'll see in that particular area?
Sir, full marks to team A now.
Full mark to team A. Yes, madam.
Okay.
Sir, it has 4 components. One is pulse rate, where pulse rate is more than 90. Pulse rate more than 90. Respiratory rate more than 20 or PaCO2 less than 30. And when there is hypothermia or hypothermia less than 32 and more than 36. And but WBC count where there is less than 4,000 and more than 11,000.
Perfect. I think, madam, they perfectly answered the question.
Okay, ma'am.
Yeah.
Full marks, team B.
Full marks to them. Yeah.
Sir, one more question to each team.
Okay. Team A, which are the long-term preventive measures, rehabilitative measure you will take in burns?
Long term, one is the positioning of the patient, sir. Because to prevent the contracture, we need to keep the hands, upper limbs and neck in the proper in the position, the intrinsic plus position and the neck in extension, and then
Axilla in complete abduction and 10 to 15 degrees of extension.
Okay.
Knee in extension position.
So splintage in pressure.
Yes, sir.
Right. Team B, tell us about the scar and the prevention of different type of scars in burns.
For scar prevention, we will use pressure garments, silicone sheet, and massaging of the healed scar with paraffin oil or silicone gel, sir.
I think, madam, they have answered very perfectly.
Okay,
very
sir.
satisfactory.
Okay.
Yeah. Thank you.
We'll invite the other patrons to ask few questions. The other judges.
See, all the
Doctor,
suppose all the 4 limbs, I can see in this picture, the IV line is on the left upper limb.
Left upper.
Okay. Suppose all the 4 limbs are involved and the patient is in tertiary, in primary health center, as Dr. Pallav was telling. So where will you put the IV line?
If it's the external jugular vein, also can be used, sir. In the primary center, if the person is well trained in the external jugular vein, he can.
Suppose he is not.
It's a trick
Okay,
question.
Yes, sir.
Suppose he is not. He doesn't know how to put central line.
So in the left upper limb, there's a cubital vein is also
No, whole thing is burnt.
Yes, sir.
And IV line is a must.
Yes, sir. Then if the person knows how to do a venous cut down, also is one of the thing which can be done in a periphery where it's not accessible. The saphenous vein can be used for the venous cut down, sir.
Why only saphenous vein?
So you told the upper limb is not like you have cubit.
Yeah.
Yes, sir. This is the anatomy is fixed anatomy like, comparatively, and it's easily accessible, sir.
So yet what do you call this process? Now you people are having Venthon and other things. So
venous
you
section.
don't.
That's a venous section.
What do you call this?
It's a venous section, sir.
Venous section. Okay. Now,
Can we give them full marks, sir?
yes. The
Team
other
B.
team, why do you calculate at all the percentage of burn? What is the importance?
Sir, team A or B, sir?
B.
B. So many formulas all come to one place only ultimately. Why do you calculate?
Sir, the rate of extravasation of the fluid due to capillary leak depends on the surface area, sir.
No. The other team, why do you calculate fluid
And
requirement?
Fluid loss also, fluid loss because of a loss of the protective.
What is the purpose of calculation? What do you want to achieve through calculation?
Sir, when if like, is it a past question, sir?
Yes.
Yeah, pass.
Sir,
Yeah.
if the percentage is like if it's more like beyond 20%, the manifestation is systemic, sir. It's not like only it's not
I'm not
localized.
asking percentage. I'm asking why are you calculating?
What
Because
is
in the
the
children, sir,
purpose
in
of
adult
T?
and children, the body surface area varies as per the age, sir.
I'm asking very basic question.
What is the purpose? Why you are, where
Purpose.
you are using this TBSA?
Yes, sir. Like to know the mortality or morbidity, like to know like because the percentage depicts
You are beating around the bush.
fluid
Tell me
resuscitation.
precisely, straightway.
Arey, what
Fluid
you are?
resuscitation, sir.
Sir, can we?
The team B.
Sir, for resuscitation, proper resuscitation so that we don't lag behind the fluid.
The answer is you don't want to overhydrate, you don't want to underhydrate.
Fluid
Okay.
requirement you want to
Now
calculate.
you tell me during the first 48 hours, when you are considering the urine output, what is its importance? You have put a catheter, there is a urobag, and the urine output is much below required.
So this is for team A, sir.
Yeah.
So the like after fluid resuscitation, the best clinical method to assess is the adequacy is by the best method of assessment of resuscitation is by output.
You have calculated the fluid, you are giving accordingly.
Yes,
but
sir.
the urine output is not there as desired. So what will you do?
So we can titrate up the fluid which is been given, sir. As per the urine output, if it is less, we can give the increase the urine flow rate.
No, you do a blunder. Other
So
team.
Sir, if after proper resuscitation, if the urine output is not adequate, I will check for a catheter block. If there is not any catheter block, I will think of a renal issue, suspecting an acute kidney injury or.
I told you, I gave you the hint. First 48 hours. What happens? Dr. Pallav was discussing it earlier. What happens? Urine output is not as per your desire. So will you give mannitol? Will you give catheter functioning is okay. Will you overhydrate? What will you do?
What will you check?
I will check for the renal parameters, sir.
Okay, let me put a straight question.
Yes.
What do you understand by diuretic phase? And when it happens?
Diuretic phase. Diuretic phase is where the
it happens after 48 hours, sir, because in first 48 hours there will be increased third space loss.
So why it happens?
Because of increased capillary permeability.
Yes. So in the first 48 hours, what happens? And after 48 hours, what happens?
In first 48 hours, despite providing adequate resuscitation according to the formula calculated, the output will not meet the required standards because of increased loss into third space. But we will continue giving the same volume only. After 48 hours, this volume will shift from extravascular from third space to intravascular compartment, which will
Yes.
urine.
So there will be diuretic phase.
Yes, sir.
And the urine output will be much more.
Yes, sir.
Isn't it?
Yes, sir.
Your urobag will be filled very frequently. Okay. Now the last question.
Sir, is it, so the team B gets the full marks, sir?
Yes. Yes. Last question. Why do you want to get this patient to ICU? What is the advantage? Burn ICU.
For which team?
Team
So
A,
this is
team
for
A.
the
Team A. Roll up burn ICU. Will this patient be benefited?
Yes, sir. The patient will be benefited since one is such this is a child with an extensive burn. So as per calculation, it's more like almost like more of 40% burns. That is one thing. And for monitor analgesia for the fluid, one thing is for the fluid management, and also for the analgesia, if you are giving opioids, we need to monitor the patient in the ICU.
Suppose this patient is having this much of burn,
Yes,
and you may not go to ICU. But what is the definite indication of taking a patient of burn to ICU? Suppose this you can manage in the ward. Definite indication to ICU.
Inhalation, presence of inhalational burns.
Yes, yes.
And yes.
Okay, sir.
Sir,
Not
sir,
only-
madam,
not-
one more
not only-
question.
Sir,
not
one
only
more
in-
question to the B.
Team B.
It will complete, sir.
Yes. So suppose you want to assess clinically the depth of burn. There are variations. I can see it here. So how will you assess which one is first degree, second degree, third degree, very crudely?
Sir, already this was asked by Pallab sir.
Pallav sir. Yes.
Yeah.
Yes. So suppose the right upper limb, you can see a dressing. And in that dressing, maybe the radial artery area is also involved. And it gets ultimately exposed. Only that much area, how will you cover? The radial artery area is exposed, of course the radial nerve also. How will you cover that area? Suppose the wound has healed and that area, the radial artery is pulsating.
Sir, when the child presents, no?
No, later.
Then we will since the vital structure is exposed, we will.
It is vital.
Vital structure is exposed. We will provide a flap cover to that area.
Where from?
From we can go for pedicle groin flap cover that area.
Now, how will you decide whether it's a groin flap or a local flap you can give? How will you decide?
When adequate local tissue is available for a transposition flap, we will consider.
So when you transpose a flap, will it be superiorly based or inferiorly based? Which one will you prefer?
So, superiorly based.
Why?
Sorry, inferiorly based, and because
inferiorly based means distally based.
Distally based because proximally there are more tissue for.
So in limb reconstruction, you will prefer a distally based flap or a proximally based flap?
We would prefer a distally based flap because more proximally more tissue.
Oh. That's the basic principle. That's a wrong answer. Okay. Okay, they don't get marks for this question.
Thank you, sir.
Thank you.
Rohit,
Madam,
I think we'll go to the
Third spotter.
judges' remarks, judges' gist of the spotter.
Yes, ma'am. Angelina ma'am.
Angelina ma'am.
This is actually a major burn in a pediatric child, which has been well discussed. I think this is enough for this because already enough of discussion into the resuscitation and the early management has been done, madam. So we'll wind up with this and go to the third spotter.
Ma'am, with your permission, I would like to know from PG teams as well as the senior most people. Why can't we cover this wound with collagen if they come immediately?
Collagen can be used for trunk and if at all for the lower limbs, it should be done not as a circumference, but one side at one time and probably after about 12 or 24 hours to the posterior side. Because if you are applying it on the same time, it may produce a little constriction.
PG teams didn't opt the collagen at all. Team A?
Yes.
What is your explanation? Why you don't want to cover any area of this child with collagen?
Ma'am, at that time question was asked like patient was in your hospital and you have all the things available, sir told. So
Yes,
I opted for
that's
the
why
best
I'm
one which was
asking.
there. Is
That
like
is
the
the
best one
reason
which,
I'm asking. When the patient
even,
comes to you, what is your
yes, sir.
preference of the procedure for this
Yes, sir.
type of wounds?
Collagen again absorbent thing will not be there, ma'am, but it's also like one-time dressing where it prevent further dressings. But here the perineal region is also involved, and there's high chance of there's a soakage and also contamination. Even collagen can
Yeah, you
get
can
sloughed off.
select the dressing according to the part and the type
Yes,
of
yes,
the
ma'am.
wound also.
Yes, ma'am.
Palak
Yes,
sir,
ma'am.
do you think it is not a recommended thing?
Ma'am, collagen is always an option in case superficial dermal burns are encountered. It is a very good modality. It is just that somehow we have got used to the new fancy.
No, just I want to
collagen is always an option,
emphasize the importance of the collagen to the PG teams. I asked this question.
Yes.
So definitely the anterior aspects and the trunk, upper limbs, the patchy areas also can be covered, and the rest of the things which you can't cover with the collagen can be go with the silver foam dressings and all.
But let me correct it. The
Yes,
team A said it's one-time dressing. Collagen is not one-time dressing.
Sir, most of the centers we use only one time and we are getting good results, sir. That peeling and removing, if there is no underlying collection, is not at all recommended, sir. So many people, they say repeated dressing and all, but once it is covered within 6 hours with sterile techniques, definitely there is no need.
Yeah, and I think the PGs must understand that it is not indicated in
deep burns.
Correct.
In deep burn as well as in superficial burn. It is only for the dermal burn.
Second degree superficial.
Second degree.
Superficial.
Not first degree, not third degree.
Yes, sir. And we should not wait more than 14 days also, or any collection is there. We have to observe.
Can I have an addition to the discussion?
Because the company people say that it is applicable for all types of deep burn, etc., etc.
No, sir. No.
Can I add to it, madam?
Yes, sir, definitely.
There was a question from Professor Bhattacharya. The indication for having this patient in an ICU, obviously intensive care unit for a burn patient is essential. It is not just respiratory burns. In a children, the most important part is the temperature regulation of the patient.
Yes.
So which you can maintain inside, especially in summer seasons, inside an ICU, it is possible. So that is very important. Second is you can monitor the patient with the monitors not only for having a definite about the hydrations. You can put a central venous monitoring cannula where you can monitor with the manometers, which is more appropriate and adequate to know exactly the hydration has been properly given, it is over or under. I think there are so many advantages apart from you are isolating the patient from the general ward with the infections. So regarding the collagen, I think what Madam and Sir, that was a little different, but in our place we have been using for a long time. We have seen after 4 to 5 days, if the patient is having a fever, especially this child, you have to open the dressing and try to take out the collagen because the collection in underneath is likely to have caused infection. And it happened in one of the private hospitals in Bhubaneswar. They had to go to St. John's, just because a patient was having fever and not getting out, because the surgeon has put a dressing with a collagen for a long time, maybe 8 to 10 days. So all these things has to be monitored intensively, and the ICU is very essential for burn patients, not only inhalation, otherwise also. But again, the question is its availability and expenses. These are the constraints. Thank you very much, ma'am.
Thank you, sir.
I totally agree. Only thing I wanted to know from them also that which is an absolute indication of ICU. If you have a thermal burn which is not involving head and neck and with involvement head and neck, then head and neck area or inhalation burn will take priority.
Even children with high percentage,
Yes, yes,
definitely, sir.
surely.
Yes.
ICU is the ideal.
Yes, sir.
Because all monitoring is
Monitoring
possible.
and
Absolutely.
resuscitation,
Sir,
critical
we are
care.
talking of a child, sir.
And there is a team approach.
Yes, sir.
We are talking of this child, sir.
Yeah.
Rohit will move to the third spotter. Now we'll invite the panelist, Dr. Harshvardhan, to start the spotter, and later Dr. Manjula Bai to moderate the session, and Dr. Vijay Joseph to give the test. Dr. Harsh?
Yes, ma'am.
Yeah.
Hi. Dear friends, I think both the teams you're doing really well. And now we come to something I think which you will be more familiar and a chance to increase your scores. So my first question would be to team A. Okay, fine. So team A. So this is a 3-year-old child who has had a post-burn contracture for the last 6 months, right? Now I would ask you, what are the points that you would look for in history when you see such a case? There are 4 things that I'm expecting, and marks accordingly.
Yes. Then what is the mode of burn, sir? First one.
Okay, good.
And the duration of exposure and the resuscitation method, what was used, like, or the dressings, what was done, and the splint age.
Yes.
Yeah, like, and the post acute management, how was the physiotherapy what was followed?
Okay, that is a part of splintage and therapy. What else? So whenever you have a contracture, there are 4 things that you need to ask. 2 you have answered, 2 are remaining. Okay, I think 1 point we can get.
Other team?
Yeah, so team B, would you be able to complete? Hello, team B.
The duration it took to heal wound to heal.
Yes. The amount of time that it took to heal.
And any procedure has been done for.
Good. So those are the 2 other points that we are looking for. We're basically looking for 4 things: the type of burn, whether a surgery was performed or not, how long did it take for the wound to heal, and what was the post-operative, whether there was splintage provided in the post-operative period. Okay, so I think another 1 point to the team B as well. Okay,
So
now
both teams get 1 mark, sir.
Yes.
Both teams 1.
Correct. So in terms of further discussing these points, so team B, what would be the difference in terms of the modality of injury on the contracture that you would expect? So say the etiology of burn, right? Whether it can be either a scalp burn or a flame burn or an electrical burn. How would it differ in terms of the contracture that you would expect?
Team B.
In this case, it might have been a contact burn or a flame or electrical burn.
No, I'm not asking about this case. I'm asking in terms of etiology, how does etiology affect the type of contracture?
Mostly the contact electrical and flame burns have produced a deep burns which causes contraction. Usually, scald burns heals within 2 to 3 weeks, so that there won't be sequelae of burns like hypertrophic scar or contracture. More towards
Team A, right? Okay, Team A, would you like to take this?
Yes, depending on the mode of burns, like for example, if the flame burn, just the duration of exposure will be just in a flash of second, whereas in case of contact burn, the duration of exposure will be more and the depth will be more instantly. The scald burns, depending on the temperature of the fluid, again the depth varies. So like this, like for example, electrical burns, even the duration of the voltage will be more and the damage to the tissues also will be more. So like this is how it differs in each mode of burns.
How would that differ in terms? So far you've sort of mirrored what the other team has said. So how would that affect the amount of contracture? How would the contractures differ?
Yes, wound healing varies, like again, and the depth again, like superficial burns, the second degree burns will heal without any scar formation, whereas the the deep burns will heal with scar formation, and the positioning of the child also varies again depending on the pain.
Yeah, no, we're going off it. So basically, in case of flame burns, in case of scars, it is usually a superficial burn. Flame burns will usually.
If they have
No point.
answered, allot the marks and ask the next question.
Right, ma'am. Okay. So, no, I don't think we've covered we've got the answer. So I think we'll go to the next question.
Yeah.
No
If
marks
you
for this
want
one.
contribution, ask the other team.
Yeah. No, I asked the other team, ma'am. So this was
Okay.
then forwarded.
Okay, then
So
they will get 1 mark. And
1 mark
the original team doesn't get any mark.
now I think we can give the 1 mark to the original team.
1 mark
1
each.
mark to the original team. Yes.
Okay.
Right. Okay. So when we talk about contractures, what are the different types of contractures? Can you explain what is an intrinsic and what is an extrinsic contracture?
Team A.
So this is for team A. Okay. Intrinsic contracture is from the tissues, like for example, tendons or anything. Like extrinsic contracture is from the scarred skins.
No. Team B.
No.
Team B.
Intrinsic contracture is due to the scarring of the burn by healing of the affected tissues, whereas extrinsic contracture is due to the surrounding tissues which produce a scar effect.
Yes. Yes. So intrinsic contracture
Example
is
you
a
give.
contracture. Okay. Yes, please.
Intrinsic contracture, this PBC hand, post contact burn of hand, the post burn contracture which develops is an example of an intrinsic contracture, whereas the contracture bands that appear in the palm are example of an extrinsic contracture.
I think he's got the gist of it, although he's not given a good example.
Yeah, correct. Yes, they have the concept, so you can give the mark.
Yes.
So
Yes.
1 mark
In a
to
PBC neck, if there is a pulling off the lower eyelid, that is called at the chin or a lip. So
that is
the
a
lip,
extrinsic.
yes, intrinsic is the neck and extrinsic is the lip, eversion and all.
So 1 mark to team B for a carryover answer.
Yeah.
Yes, ma'am. Right.
So now the question is to team B.
To team B. Yes. So when you are looking at a contracture on inspection, what do you look for? What are you seeing? What is the points that you see in a contracture on an inspection?
On inspection, we first look for the length of if there is presence of any contracture bands, length of the bands, pliability of the scar tissues, on then whether it's crossing joints, if it's crossing joints, position of each of the joints, and the range of motion, active and passive range of motion. Then
And to the aspect of the scar, we will look for the pliability, thickness, color, maturity of the scar.
Good. So I'm satisfied with the answer. I think we can give the point to
Full marks. Full marks.
Team B. Right. Team A, they mentioned something about maturity. What do you mean by that, and what is the implication of that?
The maturity is like whether the scar is just pliable or it will indent, it's like the range of movements can be like, is it yes, is the scar is supple, or just is it yielding on pressure,
No,
or it's breakdown?
Team A, I'll simplify the question. So, what is a mature scar and what is an immature scar? Give me the characteristics of a mature and an immature scar.
Mature scar will have a normal color of the compared to remain skin, whereas the immature scar will be pink, or it will have a redness, and mature scar will not show the signs of hypertrophics, or like the thickness will be normal as the like that of a normal skin. Immature scar can have it can be thick again. The color again, color one I told the.
Immature scar can break on pressure, whereas mature scar will not break, or there will be no breakage of the scar on pressure. And the arrangement of collagen fibrils will be different in mature and immature scar, whereas it is randomly aligned in immature scar.
There is one important point that I would like to hear when you are differentiating.
Second team.
Okay,
Team
so I
B.
think a point for that. Team B, would you fill in the gaps? Anything would you like to add anything to this description of mature or immature scar?
immature scars are blanchable on pressure,
more vascular.
Yes.
Whereas mature
Yes.
Non-blanchable. It will align with the tissue more. There are more pigmented as surrounding tissues. As the mature, immature will be hypo.
Yes, so blanchability is a big point. I think, ma'am, a point to each of the teams.
I told that, sir, blanchability, the pound pressure, it will be play pink, and the
They
first
told
point only.
yes, they told that.
Right. Okay. Fine.
Okay.
So full marks to team A.
Full marks to. In that case, full marks to team A. Team B. What is the implication of immature scar in contracture release?
Sir, we don't do contracture release when the scar is immature, sir. So we will wait for at least to the scar to be mature. Then only we will plan for any release procedure, sir.
Why is that?
We need to the scar with the. We need the vascularity and all to subside, and the scar to be more stable.
Can you elaborate? Vascularity is not an issue. It is a vascular scar. What is the problem if you operate in an immature scar?
The surrounding tissue will be also the scar is still in the healing process. We need it to be
local tissue arrangement will be difficult in an immature scar due to.
I'm sorry.
Sir, while releasing an immature scar and followed with reconstruction with local tissue rearrangement, it will be difficult due to tissue breakdown.
In immature scar, there is a chance of hypertrophy also, so that it will settle down in contraction. In a mature scar,
I think we'll give team A a chance. Team A.
Immature scar will be hyperemic. If you try to release, the bleeding chances will be more. Again, the high chances of recontracture will be more. And if at all you are doing it, you have to excise that completely, and then you have to do the grafting or whatever flap or any tissue cover.
Yes, yes. So that is perhaps a better answer. Points to Team A for this. Team A, what are the exceptions while operating in?
Harsha, one more question
Yes.
to each team from your side. Time is okay.
Yeah.
Yeah.
Oh, acha, okay. So then we'll, instead of going to other things, here we have a case of PBC fingers, right? Team A, how do you classify this contracture?
Classification, it's classification as per the McCoy's. This is there's a flexion contracture at the MCP joint, and at the there's an IP joint of the flexion contracture of at the MCP joint at D1 and D1 and D2 and D3 at MCP joint and the IP proximal interphalangeal joint, and it's
Team B. How would you classify or grade these contractures?
In this
What is the classification? What is the grading of these contractures? How do you grade finger contractures?
I would grade it as moderate, sir.
Is
How?
there any?
But what is the grade?
Moderate grade requires extension of the IP joints on the second figure. We can see that the IP joints can be extended.
So what is the class? What is the grading?
Any name is there for the grading? Team A or B?
McCullough's grading, the M starts with the particular word I am not in. Starts with M.
Now you explain.
And it has 4 grades, ma'am. One is mild form, that is where the joint movements are like, even though there's a post-blunt contracture, the joint movements are all normal. There's mild restriction of joint movement in the grade 2, and moderate and severe but in mild grade, in the grade 2, it's like in the passive movements can be possible. And moderate, there'll be obvious deformity, though active and passive movements cannot be done at that joint.
Grade 4?
Grade 4, bony.
Yeah.
Bony involvement, the orthodesis will be there. So
joints.
Joint fusion will be there.
So can we give them the full marks?
Yes, it's fine.
Team A. So one question to Team B, no?
Now to Team B, so how do you plan to correct this deformity?
I will try to excise the scar and release the I would excise the contracted scar and release the creep of second and third web space with the
So why do you say why would you excise the scar? What are the indications of excising the scar? What are the pros and cons of that?
In excising, we are getting rid of the scar and we are resurfacing it with STSG or FTSG, and we are getting a pliable tissue where we can release the scar and
so perhaps not. The indication of an excisional release is if you have a hypertrophic scar, right? If your scar is here, you may be served with an incisional release as well. you may not require a excision clip. Perhaps we can give 1 point to Team B for this.
Okay, okay, sir.
Team A, how do you determine
Harsh,
the?
I think
Yes,
we
ma'am.
can stop now because we have to
Okay.
move to the moderator questions.
Right.
Okay. We'll invite Dr. Manjula Bai.
Yeah, good evening, madam. Good
can-
evening, all professors and panelists and moderators. Thank you. All the questions and answering is going on very nicely. From my side, sir, Dr. Harsha was explained about these the preoperative and also the part of the contracture status and all. Are you audible?
Yes,
Yeah.
Yes.
Team A
So,
question.
Yeah, madam. Team A, my question is, if the patient comes to you on the day of burns, I mean early phase of the burns, how do you manage the burn wound of the hand? Is there any special mode of dressing is there for the hand dressing?
Ma'am, yes.
The,
Yes,
yeah.
we can. Yeah, like one is like you can use a BioBrain dressing also, like it comes with a gloved this one and proper splintage also. One is that is the one and to keep the hand in the intrinsic plus position, which will prevent this contracture. So that is the one which we will follow.
What is this ideal hand dressing, and what is the position of the?
Yes, ma'am. That is like wrist should be extended 30 to 40 degrees, and at MCP joint it's 40 to 70 degree flexion, and the extension of the interphalangeal joints, and thumb in abduction with pulp facing towards the fingers.
Dressing also you tell. You told the position splinting.
Yes, ma'am.
She asked the dressing. How will you do the hand dressing?
Some separate individual fingers will do the dressing. Will not do like a whole hand dressing. Will individual finger dressings will prefer to do it, ma'am.
You told Dr. BioBrain. What's
Yes.
the use of you applying the BioBrain at a first day or second day of the hand burns? This is looking like what type of burn injury?
Looks like a thermal burns. Like it looks like more of the thermal burns, ma'am.
Yeah, thermal burns of which category? Are the first degree or second degree?
It's the second degree, ma'am.
Yeah, usually this type of contractures will be on a second degree burns.
Yes,
So probably second degree burns will leave the scars. And if it is not properly splinted and all not maintained in a anatomical position, then it will lead to the flexion contracture. As the baby is also non-cooperative or based on their status, it will be okay.
They told the splinting position and all. If it is correct, as they answered well, mark can be given, and you ask the question to Team B.
Yeah, next.
Yeah.
Yes, ma'am. Yes, ma'am. Yes, Team B question.
So 2 marks will be given to the
Team
Team
A. Okay, madam.
Yeah. Shall we prevent the contracture in the first phase of treatment itself to this baby?
Yes, ma'am, we can by proper splinting and proper follow-up of the patient, we can prevent the.
So at what time? So it's already team A doctor was told that it's a second degree burn. So how do you treat the second degree burn? That shows that there was a granulation tissue was left after the due time. So that time, how do you manage to avoid the contractures?
We can avoid by we can go ahead with the early excision of the dead tissue and early resurfacing with the graft.
What is that procedure known as?
Tangential.
Already.
Tangential.
Yeah, that's what you use these technical words. Yeah, serial tangential excision followed by. Yes. Then grafting. What kind of grafting do you want to put?
Split thickness only, ma'am. And then
split, there are various categories are there. Na?
Maybe in intermediate thickness.
Yeah, intermediate thick skin grafting. Okay. And then followed by? So by applying this intermediate thickness, it will not
will it prevent
the contractures. Afterwards, also you have to take care in a proper manner by what way of techniques.
What measures you take post grafting?
Post grafting, we'll just split the hand and give adequate
hand or finger. Do you give the splintage to the hand or in a finger?
We will give separate dressing for the fingers and splint with the web spacers, ma'am. So that
yeah, yes,
so it won't happen. Creep and all doesn't happen like this case.
Splintage alone, or is there any other thing extra to do the suppleness of the skin and also?
We will then after healing of the graft, we will advise for scar massage and apply silicone gel
and pressure garment usage.
Active and passive physiotherapy also. All this collectively will prevent prevent the this type of contractions in a girl, these children. Okay.
So
Yes,
we
okay,
can give full marks.
Yeah, full marks. So team A, another question. Okay, this is looking like it's a matured scar. So what is the technique you follow to release this contraction in this case?
In this phase, like we can go with incision of the scar and like I'll put resurface the raw area with intermediate thickness skin grafting, and I'll see the joint mobility. If required, I'll put a K-wire also in this patient, ma'am.
So, okay, how do you say that it's supple? Okay, but is there any alternate technique?
Z-plasty also can be done for this patient, and then the contracture band you can do a Z-plasty also.
Okay, why can't you follow that Z-plasty principle? By following the Z-plasty principles, is it possible to do it here?
One finger we can do it, ma'am. In the other finger, it doesn't look like a contracture band, ma'am. The D4 you can do it. The contracture band is there. That you can go with the Z-plasty. And other finger, like it's more of a whole width is involved. There I need to
The middle
incise and
finger.
put it. Yes.
Middle finger
Yes,
is looking
middle
like
finger, yes,
thicker
ma'am.
than the
Thicker
ring
than
finger.
the ring finger, ma'am.
Okay. So what is the principle behind this Z-plasty?
It's a double transposition flap.
Double transposition of?
It's a double transposition flap. It basically helps in it lengthens the scar, whereas it shortens the breadth of the scar.
Okay, what is the angle do you want to take? Where are this? According to the angles, we can lengthen the scar, no?
60
Which
degrees.
angle you
60 degrees is the commonly used.
So commonly using 60 degrees.
60
With that,
degrees.
how much of length you will achieve?
50% of the length you can
75 or 55?
75, 60, 75%. 45 you will get 60, then 75.
Yes, okay. But it's a two different techniques may be possible to do it here.
Yes,
And followed by the proper splintage is also essential here. Okay. This
Yes.
for this. Okay, ma'am. This
Full marks to them.
Okay,
Team B, madam.
Team B questions. Okay. How do you differentiate? This is a Team B. Is it a soft tissue shortage or a tendon shortage? Are you able to understand?
Yes, ma'am. Since the distal interphalanx DIP joint is getting extended while pulling the fingers, I think the tendon might not be that shortened. Only the skin covered over the. So
how do you test for that? How do you test for that?
Team A.
Like when you flex the wrist, you can, if you are able to easily extend the fingers, then it's saying that that's not because of tendon shortage, ma'am. If on the flexion of the wrist,
I can't able to understand. Yeah, what's it?
on flexion of the wrist, ma'am, if we are able to extend the fingers, then that's not because of tendon shortage, ma'am.
MP
And
joint. On,
yes, wrist.
on flexion of the MP joint.
Yes, MP joint is MP joint.
Yeah, not the.
Yeah, if you're able to
Proximal
extend the
joint.
fingers, then
proximal
it's
joint.
not because of. Yes, ma'am.
Okay.
Yes, ma'am. On the
Team A gets the mark.
One mark. One mark.
Yeah.
Okay.
1 mark.
1 mark. Okay. Madam,
Now the question, primary question to team A.
Okay, madam. Next, another. Is there
one more question to each team, ma'am, from your side?
Myself, ma'am?
Yeah. One question, that's all.
Yes.
Both
What
the
is
team.
graph? Yes. What are the in the remodeling phase of the graft take? So how the sensations, nerves, this moistness and everything. So following grafting, we feel like a scar is dry, shriveled, and it's become sensations less. So what are the criteria of regeneration of nerves, sensations, sebaceous, and sweat glands in a grafted skin?
what are the criteria?
Have you understand the question?
Ma'am, can you repeat it again, ma'am?
Yeah, it's known as graft care.
Yes, ma'am.
Graft care for any surface or anywhere in the body. Following the graft, we have to observe that whether the graft is regenerated completely or functioning it normally. To say what is the timeline for the regeneration of the nerve to achieve the sensations and to achieve the moistness by sebaceous and sweat gland regeneration and proper vascularity. This is known as graft care. This is
6
a
months,
common
6
process of
months,
graft.
by 6 months, ma'am.
No. Just like not like each one have an different timing. Okay.
When will the graft vascularize totally? When will it get sensations? What madam was asking.
Yes, ma'am.
When the skin gets the
moist,
sebaceous and sweat glands, the graft. So she's asking the time when they regain. Approximate or it is given already.
That's why we have to instruct the discharging patients to follow the massages, active and passive physiotherapy till the patient gets all those functions. Okay.
Team B, you want to tell?
Team B.
Ma'am, in split thickness graft, usually the sweat glands are they don't gain their complete function, whereas in full thickness graft, sweat glands and sebaceous.
Intermediate thickness you are giving, isn't it? You are giving intermediate thickness.
In intermediate thickness,
intermittent thick.
The sweat glands take approximately around.
So what are the structures?
Sweat glands take 4 weeks to regain function.
4 weeks. No. Each structure will be starts.
Yes, let them answer. If they are wrong, you please tell.
Yes.
Tell the time. If it is correct or not, we will decide.
Glands is by 4 weeks, nerves by 6 to 8 weeks.
Now ending, sir.
Team A. It's wrong. Team B is correct, not correct. Team A, you also tell your times. Duration.
We need to guess on the exact numbers and no.
Okay. Then
Both
shall I
will not get the answers. Madam, you also tell.
So revascularization starts by 5th day onwards, and then anyhow this vascularity will be continued from the first week onwards. So no bothering about the vascularity and the graft uptake. But the thing is here, sensations. getting up of the sensations at the early phase, that is at the end of 4 weeks, the patient may have some sort of tingling, some sort of hypersensitivity and all. That is the sign of regeneration of the superficial nerve endings. So from then onwards, it will become starts matured and become normal by the end of the 6 months. And later on, these sebaceous sweat glands will regenerate and reaches to the maximum up to the 1 year or sometimes up to 8 to 12 months. Why? Because this is intermittent thick split thickness skin graft. We won't get the sebaceous glands and sweat glands. Why? Because this was just underneath the intermittent thick. So moistness will be not proper till up to the 8 months to 1 year. So that's why we used to insist the people to use the moisturizers up to the 6 months to 1 year to avoid this eczema, post-operative complications like dryness and shriveling and all in major grafts. Okay. So earlier is the vascular one, and then nerve endings, followed by finally is the moistness will come. So it will take up to the 8 to 12 months. Okay.
Okay.
Yes, ma'am.
I think both teams equally the questions were asked by Dr. Manjula.
Yes, madam. Yes, yes.
So we'll move to the patrons' questions.
In the right picture, what the surgeon is trying to assess?
Team A.
Team. To check, is checking for the scar contractile and also the suppleness of the joint also, like whether he is able to extend the IP joints.
Okay, one is joint suppleness. What else?
Yes, sir. And that contraction bands also is checking for the contraction band.
Right. Anything else? Team B.
Looking for a tendon shortening. Tendon shortening.
Tendon shortening. You are leading to another question which I'll ask later. Anything else?
So any color changes in also you can check whether the mature scar if it becomes pale or anything pale.
Okay, I'll give 1 marks. The answer is more than that. You see how the web space is moving. Okay, release of contracture will correct the web.
Yes.
And the palmar skin, the palmar creases. That leads to the next question.
Team B.
Team B, which Harsh has
They'll
already
give the 1 or 2 marks, sir.
1 marks.
1 mark.
So Harsh has already asked, but I will continue with that. What is and Madam has also said about extrinsic contracture. So what is the importance of extrinsic contracture? Extrinsic contracture occurs adjacent to the intrinsic contracture, okay, in the adjacent tissue. So what is the importance of extrinsic contracture? Knowledge of extrinsic contracture.
We need to release the site of intrinsic contracture primarily in order to
and check the adequacy of release of extrinsic part also.
Adequacy of release of intrinsic contracture. That's the correct answer. Okay, that means they will go back to its normal position. Okay, now coming to the
So any marks, sir? Any marks
yes,
to them?
1 mark. 1 mark.
Okay, what?
Now coming to the tendon shortening. Both the teams said tendon shortening. Why in contracture there should be tendon shortening or anything else?
Because of the it's the contracture like collateral ligament shortening, so not and all. Tendon shortening with long duration, the tendons will go. Sir, exactly.
Yes, please.
Contractures that remain for a long duration can lead to shortening of tendons.
Is it tendon shortening or tendon adherence?
Integrated of the tendon, integration of the tendon into the contracture.
If it is tendon adherence or tendon shortening?
Tendon adherence.
Tendon adherence. So after releasing of the contracture adequately, if you find, what will you do? Still there is contraction effect.
Contraction of the tendon, sir.
How will you handle the tendon in that situation?
We
can do tendon lengthening procedures.
Is that
no? Short of tendon lengthening. Have you ever seen tendon lengthening is being done in such type of contracture?
We can,
sir, we can give series.
So you do tenolysis. Answer is tenolysis. Okay. And the question is, how do you do tenolysis?
So no marks to them, sir?
No marks to them. What
So
precaution you take? What precaution you take doing tenolysis?
Team B now.
Team B.
We will not injure the paratenon and the vascular supply.
Vascular supply is not a problem. There are pulleys.
We ensure the pulleys are not damaged.
How many pulleys?
5 A1, A2, A3, A4, A5 pulleys. And
you said
annular and cruciate pulleys. Annular are 5 in number and cruciate are 3 in number.
Yes, I will give you one mark. You said I will incise and release. Then the scar tissue remains hanging on either side?
This question is for team, sir.
Yeah.
Sir,
will you incise or excise?
Sir, we can incise and put a graft here, sir.
Then the scar will remain?
Sir,
your aim is aesthetic and functional recovery?
Yes, sir. Primary is the functional recovery, and after that is the aesthetics. Like
so again you will go back and excise the scar?
Yes, sir. Like at the same time we have to do both, sir.
So what will you do, incise or excise?
Sir, excise both can be done, sir, but with cosmetic, by excision and grafting will be a better option.
Okay. Next, to the next team. If you incise or excise, how do you protect the digital nerve?
Sir, marks to team A, sir?
1.
Okay.
How do you protect digital nerves?
We plan our incision away from the radial and ulnar pedicle.
I'm asking, that's why. How will you protect? What is the landmark?
Landmark is the
we take our incision just volar to the midpoint of the midpoint between the volar and dorsal aspect of the disease.
Okay, suppose your incision reaches there, then what do you do? And you have to do a fistuling also, isn't it? So how do you protect the digital nerve? Is it necessary to protect?
Yes, we should.
So how do you protect?
We will cover with
other team?
Team A.
Any Any maneuver?
We can dorsal.
By extending the finger, by extension of the PIP and the DIP joints, the nerve will be prominent. So under visualized dissection, we can avoid dissecting the nerve.
So I will not give marks.
We can consider a dorsal lateral or dorsal medial flap to cover that area, depending on the size.
No, you need not do such extensive procedure. When you reach that area which you just mentioned, then you don't use fine tip scissor. You use ball tip scissor or blunt tip scissor and try to make the release there by opening it so that the nerve is pushed away.
Yes.
Okay.
Yes.
And this is to be done under magnification. That is very important. The last question.
Sir, somewhat team A answered this.
One
Maybe the scissors they didn't tell, but they wanted to identify under magnification and dissect.
Yes, under magnification. Okay, you can give him two marks you can give. The last question is there any role of bipedical release?
Yes.
Team B.
You know bipedical release of contraction?
We can do bipedical release in the middle finger in this patient, sir. And we can resurface with FTSG.
What is the principle of bipedical release?
In bipedical release, we give two incision release with fishtailing, in leaving behind an intervening area of scar tissue, such that we can achieve and
I'm asking you what is the principle?
We are repositioning the scar from the contraction.
Other team?
Team A.
No.
Okay. So none of the team gets marked. That's it. Thank you.
Thank you, sir.
Thank you.
Rohit, any PG questions they have to ask? Arun Kumar Chaudhary, sir, would you like to ask anything?
May I ask a question?
Yes, sir. Yes, sir.
As this is a child, to which team I should ask, I don't know.
Just first
yes,
team
sir.
A and then
team A.
Okay. So as this is a child and you are going to release this contracture, post-operatively, what special instruction you would like to convey to parents?
The proper positioning of the hand and the splint, what we use should not be done. Like we can use K-wire also. Like if since it's a kid, it is we are whatever we say, there's some amount of movement the kid will do. So we'll prefer to put a K-wire and proper splintage with the proper splintage, and we'll tell the patient, the parents to keep the splintage in proper position. And
what is special instruction to parents? Team 2, B.
Team B.
We'll ask for limb elevation and look for.
All these things are they are already told.
Sir, we'll check for the vascularity, the color of the fingers.
That of course you have to see.
Yes.
I am asking post-operatively. Once you are discharging the patient, what special instruction you will convey to parents?
To continue with the massage and the range of movement.
It may be taken as instruction or information. I have elaborated.
continue the range of movement therapy and massaging of scar.
Anything else?
With apply silicone based pressure and continuous use of pressure garments.
Passive movements of the fingers and the active movement by the
So,
child.
madam, should I give the answer?
Yes, sir.
Both teams get an answer.
No
Yes,
marks.
sir.
One special, very special information you have to convey that, see, it is a child. As the
Recurrence, sir.
hand will grow, contracture can recur.
Recurrence.
So, few more operations are certainly required. Otherwise, patient will be on your head, the parents. Okay?
Yes, sir.
So all these managements will not certainly prevent the recontracture as the hand grows. So in a child, if it would have been an adult, it's okay. But in a child, you have to give this instruction. Okay?
Yes.
ठीक है, madam?
Yes, sir.
Yes, sir.
One more question I'll ask. If it is a long-standing contracture, the child sustained in the burns in the childhood, and they present at age of 14 years like that. What are the problems you come across?
Team B. Team B, madam. Team B.
Team
Question
B.
was first given,
Okay,
sorry.
okay,
Team A.
okay. Team B.
Retardation of growth of that specific limb or finger with a contracture of the tendon.
No. While doing the surgery, anything you anticipate?
The vascularity, means the vessel shortening.
So
Of.
how will you overcome?
We can use a distractor at first during the procedure, ma'am.
Yes, isn't it? What will you do? Team A?
Serial release of the contracture can be attempted than at one go.
And serial
So,
traction, skin traction also.
Partial release, you
And
will
skin
stop
traction.
there. You don't continue to release completely and go for the serial splinting or
Serial traction
Serial-
also can be advised. no?
Or multiple settings of contracture release.
no. You told some
Serial
splinting, you
traction,
told.
ma'am.
What is
Yeah,
the
skin
other?
traction.
Team B answered.
Distractor, ma'am.
Distraction and
Distractor. So you don't proceed and complete the release, but you stop that procedure and then go for the serial splinting or distraction. 1 mark each, sir, madam.
Okay, madam.
We request Dr. Vijay Joseph, sir, to give the gist of the spotter.
Good evening. Am I audible?
Yes, sir. Yes.
Can I ask a question, ma'am? Can I
Yes.
ask a question?
Okay. Yes, sir. Yes, sir. Please proceed. Your audio is not there, sir.
Am I audible?
Yeah.
Yes, yes.
Hello. Madam,
Yes,
can I
sir.
ask a
Please ask
question?
the
I'm not
question.
able to
It's
hear.
audible, sir.
Yeah. So what is a manipulation under
Team
anesthesia?
A.
Team A. And why you do it? Any contracture, even including here also.
Since it's a painful procedure, it can be done under anesthesia.
Team 2.
Checking.
Why you do a manipulation under anesthesia, not without? What is the physiological basis of it?
There will be relaxation of the muscles, and we can adequately check the movement of joints, supplety of the joints in anesthesia. Otherwise, the child won't allow it.
No, it has nothing to do with the muscle, nothing with the joints. Anyway, team 2, can you answer? It is because of the muscle that contracts and which is not possible to relax. During anesthesia, you do gradual stretching or physiotherapy or manipulation so that you get the muscle which have a gamma fiber and it gets contracted for a long period difficult. So gradually you release the contracture of the muscle. It is not a contracture exactly. It is a muscle which has gone for a temporary contraction. That contraction is relieved on gradual manipulation under general anesthesia. Most of time you don't have to do a tendon lengthening. Very rare you have to do a tendon lengthening. Very rare. So that's why either you do under anesthesia or later on you can do a traction and other manipulations or whatever. Tendon lengthening is the rarest of the rare is required for most of the cases in fingers or in other place also. Anyway, second question regarding the joints. What are the possibility of a joint in a finger joint possible to happen in a long-standing contracture?
Team B.
What are the structures are involved? This is team A question.
Team B, sir.
What are the structures are likely to be involved, and what you are going to do for that? Team B, please.
At the level of MCP joint.
Take time. Team B.
At the level of MCP joint,
Transmission.
There is.
Are you able to hear? Team B.
Yes, sir. Yes, sir.
Team B. Can you hear my question or
yes, yes, sir. At the level of MCP joint, there is the contraction of.
Bleach in the transmission.
There is contracture of the.
I am not able to hear you. In fact. Okay. Anyway.
You give the answer, sir.
Intermetacarpal ligaments are also
okay.
At the level of.
I am not able to. Yeah, the ligaments of difference and all these are get affected on the pathology of the joint contracture. Yeah, the articular cartilage, the joint space. Yeah. And what result you can get when these structures are affected? What effect you will get in the joint?
The MCP joint gets
what is a fibrous ankylosis? What is a fibrous ankylosis of a joint?
Question to be
the joint.
Fibrous fusion of the joint due to.
What is then a bony ankylosis?
The joint
what
capsule
is the
get fibrous and fixed, causing the fibrous ankylosis, and bony fixation. There is fusion of.
Yes, good. Yeah, you answer her. When the joint capsule, yes. When the ligaments joint capsules are affected, you have a fibrous ankylosis. Still, there is some movement in the joint. But in case of a bony ankylosis, there is complete fusion of the joint and there is no space between the articular cartilage. And there is a trabecular pattern you can see on the X-rays. So that's how it is a joint. It's a completely bony ankylosis. It is for anywhere, even KM joint. So in this case, if you are long standing, you need to have an X-ray for that. Okay.
Yes. Yes.
Any marks, sir?
I think half mark they will get it on the total.
No half mark, sir.
Yeah.
1 mark.
1 mark to team B, yeah?
Means, I mean, not half, means out of 2, they will get 1. That's it.
1 mark to team B, okay.
Yeah, yeah, yeah. Yeah.
Dr. Vijay, sir.
Okay. Thank you.
Thank you, sir.
Thank you.
Yeah, good evening. That was a really very extensive discussion that we've had. Just a couple of things which have come up in the discussion that I'd like to add on. One is that in the acute phase, we were saying about the functional position of the hand. Now, in a palmar burn, what will happen is that if you put them in MP flexion, you will actually encourage the contracture to happen. So you need to be careful. So this is the only situation where we would do a combination of both. So either in an older child, you can do a glove dressing and get them to be functional. But in a young child, you don't expect them to be cooperative to move. So ideally, what you have to do is you have to keep them in extension for some period of time and in palmar flexion at a different period of time. So the idea being that you prevent the contracture by counteracting that because it's a deep palmar burn, and you prevent the collateral ligament shortening by putting them for a few hours in the functional position. So you therefore prevent it from creating. So you have to do an alternative between the two. It is important to get a hand therapist involved early so that the child can then start using the hand early to be able to have all the joints mobilized. The difficulty is going to be on, do we do an early excision or not? So if you do anticipate that this is a deep dermal burn and beyond, you need to do early tangential excisions and then resurface it with a split skin graft. The problem with split skin grafts on the hand is also that it gives severe hyperpigmentation. So that brings us to a point where in releases, especially if you have small areas, there is a role for glabrous skin grafting. So that's something that you should look at because the cosmetic appearance of that is much better. All of you all have talked about the maturation of the scar. So if you do it in an immature scar, the chances of recurrence is very strong. So which is why you wait for it to mature. But if you find that it is an extremely severe contracture, you might have to accept that before it gets buried into the palm, you will release it serially. So release it partly, get as much as you can, and then release it again once you have the scar matured a little later. The classification is Macaulay's classification that we use, and it's spelled Cauley, Macaulay's classification. So it's 4 grades. In the first grade, it's just tightness. In grade 2, there is a mild deformity, but no functional deficit. In grade 3, you get a functional deficit. And grade 3 and 4 can be either flexion, extension, or both. And in grade 4, you have a severe deformity with a compromise in function. Most often in the hand, one of the things we're doing is to make sure that we provide the grips of the hand back. So that takes priority over everything else. So you have to get the thumb into abduction and able to oppose. The thumb has to be able to pinch. Then the next thing is to be able to grasp onto an object. And finally, if you can provide a power grasp, that's the best that you can do for them. When we're doing the release, we would look at the point of maximum tension, which in that particular case is probably in the region of the PIP joint. In a growing hand, you also want to assess and see whether there is any difference. If it's a long-standing contracture, is there any difference in the length of the digit, which you can actually measure on the dorsum of the hand. So in a child whose digits are smaller, you'll find that the proximal phalanx or the middle phalanx and distal phalanx are shorter compared to the opposite hand in this thing. You can also kind of anticipate the true defect by checking the defect from the tip to where you have normal skin and from your distal interphalangeal, the metatarsophalangeal joint to the level of your normal skin. So the intervening gives you an approximate idea of how much true defect you have in that patient in this thing. Again, when you're doing the release in the proximal interphalangeal joint, you have to release at the point of maximum tension, and then you have to fishtail as you go to the periphery. If you put a little stretch onto the digit, you can go a little away from the same spot each time. So you, without undermining too much on the side skin, you don't deepen it at a single point. You keep going away from the central point, and you will find that you will gradually be able to get a much more extensive release. If you have DIP involvement, you'll have to fishtail again over there. And as you do the intrinsic release, you'll find that the web space comes back to its original position. If there is syndactyly, you will have to release the syndactyly also simultaneously. We would always K-wire the joint, because in a child, it's going to be impossible to keep it otherwise. So 2 weeks of K-wire and then remove it out and then start getting them to mobilize after that. So in the preoperative counseling, we have to tell the mother that there will be a lot of scar massage. We use a Coban, which is 3M's 1-inch elasticized dressing. We teach them how to apply that, which makes the scar much more supple. Or you have to use a hand glove, which will make it supple. I find the Coban is probably a little more effective in making the scar supple, besides the massage that the mother has to do. The night splinting that we give is a dorsal splint for each digit, which you can put into extension, and that is used almost for about 6 months post-operatively. Otherwise, the chance of it getting a contracture is extensive. So at the end of 2 weeks, the mothers will start, once the scar is mature, maybe even 3 weeks, the mother will start massage, compression with a Coban, a glove compression, night splinting during the night, and active and passive physiotherapy during the day. Just one more point is about the volar plate and the joint. So if you find that the passive movement of the joint is limited, there is a possibility, but that the X-ray shows the joint space, and there is a flexion contracture, it is possible that your volar plate is stuck. So once you do a release of the finger through a small buttonhole at the level of the joint, you can go subperiosteally and release the periosteum with the volar plate on the proximal joint, so that the volar plate can then move proximally, and you'll find that most often you can get a passive range of movement at that point, which is better than the other thing is that some people use a double splint in children because they find that it is easier to use a thermoplastic double splint and strap them together as a night splint, and during the day, active physiotherapy. In the postoperative period, you have to look at the vascularity of the tip of the finger. Sometimes we've had to remove the K-wire because, especially in a long-standing case, you could have a spasm of the vessel if you stretch it completely. So you will have to release the K-wire, let it go into a slightly flexed position, except serial release at that point in time. So the vascularity postoperatively is extremely critical, and distractors are the other things that can be used to serially extend the joint. Yep, I've finished. Thank you.
Thank you, sir. Very valuable points. We have completed all the 3 spotters, sir. So we'll go. Rohit?
Yes, ma'am. Follow up.
Yeah, this is the first spotter. Dr. Pallab sir had some commitment, so he left the meeting. So this is treated conservatively, and yes, you show the other photos. You
They
can
are,
go ahead. Yeah.
yeah, okay, ma'am. This is the second.
This is the third spotter. Contract. Harshvardhan is there. So
Yes,
this
ma'am,
is
I'm here,
the
ma'am.
yeah. So it's release and grafting was done, and splinting later. Physiotherapy, isn't it?
Yes, ma'am.
Yeah. Okay.
Now we'll move to feedback collection by Dr. Umar sir. Then from the panelists and ma'am, Umar sir, I'd like to request you to come and
You can take Rohit. Sir
okay,
is not available.
I would like to
Was
request
there?
our
Dr. Uma?
Yeah.
Yeah, sir is there.
yes.
Yeah, I am not
Invite.
connecting from the laptop. I will switch it
Okay,
off.
okay.
Oh, good evening to all.
Good evening, sir.
So let us start the feedback. We'll start with the panelists. I think I could not see Dr. Pramod as well as Dr. Pralav.
Yeah, they are not there.
Yeah,
Remaining
we'll
people you
start
can.
with Dr. Harsh. Harsh, you can give your feedback.
Sir, this is my first time as a panelist in this program. I am surprised by the level of knowledge, not of the experts, but of the students in the teams as well. So it is a great opportunity for everybody to have a chance to interact with the seniors and established names in the field. It is a very good idea, and I thank ma'am for organizing this and everybody for contributing. The teams, you have done well. You have really some of the answers even I did not know, and it is a good learning experience for me also. So well done to the teams, and thank you for having me here.
Thank you, Dr.
Thank
Harsh.
you.
Now let us move to the moderators. So we'll start with Dr. Shanta Kumar. Sir is here. Shanta Kumar, sir.
I think, yeah, sir is there.
Sir is there. Sir is here. I can see him.
Yeah.
The thing is, this
Good
is
evening, sir.
actually, I am
Sir,
in
good
Plastiquest
evening.
for the last 2-3 years. It's a very good initiative by Lakshmi ma'am, and even this is not only helpful for the students by teaching. We also learn from our seniors. Actually, very good interaction. So today we thought it's actually a simple one, but it went on almost 2 hours. It's a very nice this one. I think I hope even now our PGs have joined. I think today is the first day. They are also into this meeting. I'm very happy for that. Thank you, ma'am.
Thank you, sir. Yogesh, sir.
Sir, I'm impressed by these efforts of all senior and especially the Plastiquest all host and all that. It is very nice learning platform for the younger generation plastics, especially resident doctors. And I'm really impressed by this activity, sir. This should go on and on for the upbringing of a young plastic surgeon in a proper fashion and good knowledge for them. Thank you so much.
Thank you, sir.
Thank you, sir.
Manjula Bai, ma'am.
Sir. Good evening, sir.
Good evening, ma'am. Good evening.
Nice platform for the sharing of seniors and juniors knowledge. And for the juniors, it's a very good opportunity to have a multiple knowledge, senior faculty knowledges. We are all missed that opportunity. Nowadays, Bhattacharya sir, Chaudhary sir, and Kamal sir, so many senior legend doctors are coming in the field and sharing their views. We are very much happy and we will congratulate the program innovatives and all. And thank you very much, Lakshmi Madam, for joining me in this program as a third time I'm joining here. And Umar Farid sir also, thank you very much for the panelists and all moderators and my colleagues. Thank you very much.
Thank you, madam.
We continue the same program for future also. As it's a reciprocal one. We are also learning the things which are missed in our PG period and all.
Exactly.
Very nice. Thank you very much.
Thank you, ma'am.
Yes, sir.
Now going to the judges, we'll start with RK, sir.
Nothing to say today. It went well, and we have improved quite a lot. Thanks.
Thank you, sir. Vijay, sir. Vijay Joseph, sir.
Yeah, that was a lovely session. I learned a lot, especially I'd never seen that dermatome before. So there was a lot of learning, and the students did well. I must congratulate all of them. Thank you so much.
Thank you, sir.
Thank you, sir.
Angela, madam.
Sir.
She's all time busy. She's all time busy in the whole session.
Well.
Actually, she has been given responsibility of
accumulating
the
Giving the
marks and
marks.
calculating them. And
the calculation part of it, like
Madam, announce the result.
Now let us go first. Let us go first to the people
first thing
for
is
their
I should
feedback.
Feedback, madam.
Feedback from the madam, then feedback from the PG teams.
first, the actual first thing is the new equipment. Probably Versajet is being used.
Yeah.
It is being used quite a lot in India.
Yeah. Now it is coming in almost all government hospitals,
All government institutions and big institutions,
but,
everywhere it is being used.
Maybe not all, but most of them are having. Yeah.
Yes.
Yes. So actually a lacunae in that part, in the first quarter. So the team scored only 8 and 3. But coming to the
Madam, can we stop the telling score first? Can we have PG team feedback?
The feedback.
Then we can go to that.
So good evening, everyone.
Tough
Yeah, team BMC start that feedback.
latest concepts are there. But only thing is the
Madam, Angela, madam, can we have feedback from the team?
was not.
Angeline, madam. Just a moment.
Team's feedback is remaining. So team A, give your feedback.
Team.
Before madam announces the result, teams, you give the feedback.
Before that, you take feedback from Dr. Bhattacharya too. Only in the last, you declare the result.
Sir, yes, sir. So that is the pattern. He can end the session.
Yeah.
Let us take feedback from the BMC.
Good evening, all teachers and colleagues. Like, it was a very nice session for us. Like, since we are following since last 5 sessions without missing it, almost we are like at to the PG level. I think we are like every day we are growing. Each session wise, we are like collecting new knowledge, how to read and what and all thing to be concentrated on, which burns cases. Like we are. It's teaching us more than a book, like not even more than multiple books, because all these things which we won't get at simultaneously at one point, and we are all getting through the experts with their experience. It's like we are getting knowledge more than what's given in the book and what's not there in the book, everything, including the recent advances. Like in the first slide, we were shocked that like we didn't know that instrument properly, but I'd seen once in a video with the 2 seconds, I've seen that instrument, that's it. So today we got so many information about that. So it's like really helpful for us in improving our professional careers. I thank everyone for that.
Good. Now team KM.
Good evening, sirs and everyone else. All the 6 sessions were instrumental in educating us in topics on burn care and recent advances. We could learn a lot from these sessions. what was there in the books and what is more than that, and recent practices, which happens all across the nation and according to international standards, were brought out, which was instrumental in guiding us. So we could learn a lot from this.
Especially the discussion, sir. It was really good, sir. And that discussion parts are really good, informative for us.
Okay, thank you. Good.
Thank you.
Now,
Sir,
Bhattacharya sir.
Sir, just a minute. I got my network got disconnected because of the heavy rains here. So let me announce the results. Team A got 45 and Team B got 32. The successful team is Team A from Bangalore.
Congratulations.
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 Thank you, ma'am.
Thank you.
Thank you, sir. Thank you very much.
Sorry, I got disconnected because of the heavy rain here.
Thank you, ma'am.
45, 32.
Thank you,
So
sir.
let
Thank
us
you.
go to the Bhattacharya sir.
Same difference, I think.
Well, the awards fall short in appreciating the enthusiasm and zeal of Dr. Lakshmi, Dr. Farooq, and Dr. Rohit and the whole team, Dr. Devi Prasad and the whole team. At the same time, as a little senior person, I must say that what I observed is every time